This meeting is being recorded. Welcome to the August P&T meeting. We're waiting for one more committee member to join us, so hopefully they'll be here shortly, but we do have a quorum at this point, so we're going to get going. We're going to start with roll call and introductions. Doug, if you'll lead us off. Doug, are you able to unmute yourself? Doug, I've made you a co-host, and you should have the ability to unmute.
Excuse me, I'm Doug Carr. I'm Medical Director at Umpqua Health, internist by training, and welcome to be here.
Welcome, Doug. Russ is not able to join us. We're hoping Dr. Anish will be here shortly, but she's not here yet. Eddie, we'll turn it over to you.
Hi, I'm Eddie Saito, clinical pharmacist at Virginia Garcia and associate professor with the School of Pharmacy at Pacific University.
Welcome, Eddie. And Pat isn't able to join us, nor is Kat. So, Stacy.
Hey everyone, welcome. My name is Stacy Ramirez. I'm faculty at OSU College of Pharmacy and a primary care pharmacist and the director of pharmacy at the community health centers of Benton and Lynn counties.
Welcome. And Tim?
I'm Link, director with the Klamath Tribes in Chilton.
Welcome, Tim. And Bridget.
Yeah, my name's Bridget Bradley. I'm a clinical pharmacist at OHSU Primary Care.
Welcome. And Samara.
Yeah, hi there. I'm Samara Stevens. I am a naturopath in private practice in Portland.
Welcome. Jennifer, you want to lead off the staff introductions?
Jennifer Bowen, executive support with Oregon Health Authority.
Roger Citron with the Derm Group. Trevor isn't able to join us yet, but I anticipate him later in the meeting.
Hi, I'm Dave Engen, a clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators with the Derm team.
Andrew Gibler, I'm the clinical pharmacy manager with OHA.
I'm Kyle Hamilton. I'm the pharmacy drug coordinator here at OHA.
Dan and Megan aren't with us today, so Deanna, we'll turn it over to you.
Hi, good afternoon. I'm Deanna Moretz. I'm one of the pharmacists with the Derm team.
And I'm Kathy Centena, and I'm also a pharmacist with the Derm team.
Hi, my name is Sarah Servid. I work as a P&T clinical co-coordinator with the Derm Group.
I'm Lance Starkweather. I'm pharmacy manager for Gainwell Technologies.
Dee Weston, pharmacy program policy advisor with OHA.
And hello, I'm Brandon Wells. I'm the pharmacy program analyst in the fee-for-service program at OHA.
And Ted Williams is also not going to be joining us today. So next up, we have conflict of interest declaration, really important to the OHA for transparency. All of the staff, all of my team and the OHA have conflict of interest declarations on file. So we don't have any conflicts to disclose. If we did, we would bring those forward. Similarly, all of the P&T committee members have a conflict of interest declaration on file with the OHA. It is expected, however, if that changes, we get an update from you now at the start of the meeting, or if we come across a topic for which you feel that you have a conflict, you would recuse yourself from voting. So at this point, I'll see if any of the committee have any conflicts they need to update the OHA, make them aware of. Hearing none. Also, conflicts of interests are required of people submitting written testimony and providing public comment during the meeting today. So those have been collected by me, and I will share pertinent information as we call upon people. And for the written testimony that's been on the website, I brought that to the attention of the committee so they could review that in advance. So next we have the approval of the agenda and the minutes. In regards to the agenda today, we have a very robust agenda we're hoping to get through. The one change that we are proposing is the last two topics, the antacids and the targeted immune modulators. We're going to swap the order of those. We'll see how far we get through the meeting, if we can get through everything, but if we can't, we'd prefer to defer the antacids until October as opposed to the TIMs. So that's the only change. The minutes are in the packet. For those of you in attendance, the packet of materials has been posted to our website. You can follow along. The minutes are listed on page 4 of those. I sent those out to the committee in advance so you had a chance to review. We'll see if you have any edits, but if not, we'd entertain a motion to approve.
Motion to approve.
Thank you, Doug.
We have a second.
Second.
Thank you, Eddie.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Motion carries.
Now I'll turn it over to Andrew for the department update.
Hi, this is Andrew. I don't have any updates for the committee unless someone else from OHA has an update they'd like to share. Okay. I'm going to give an update on some of the work from the Mental Health Clinical Advisory Group and some of the publications that they've put out in so far this year. We're currently working on guidance for PTSD, and then this year we've worked on finishing up updating the schizophrenia guideline, and then we approved the a document on antipsychotic induced movement disorders and then insomnia disorder. So there's our website right on that front page there. If anyone is interested, I always encourage people to go to the website and look at it. We call it the MCAG just for short, but that's under pharmacy and policy programs along with this committee, which is within health policy and analytics as part of OHA. And they're by statute required to develop evidence-based treatment algorithms for mental health disorders, and that includes advising and providing recommendations to this committee. And they use the same research methodology as the DERM group uses for this committee, but the final guidance documents will look a little different. They're written to be easy and quick and practical for busy practitioners. So we encourage everyone to look at that website and explore. Next slide, please. And so these, in April, we approved the recognition and management of antipsychotic-induced movement disorders, and then just last month, the treatment of chronic insomnia disorder. Next slide. So in this document, the treatment guidance on antipsychotic-induced movement disorders, it really highlights and differentiates the most common antipsychotic-induced movement disorders seen in clinical practice, and those are dystonias, Parkinsonism, akathisia, and tardive dyskinesia. And it also highlights the primary differential diagnoses for people presenting with similar signs and symptoms. And the overall prevalence of antipsychotic-induced movement disorders is pretty high. It's about 37%, with Parkinsonism being the most common, followed by akathisia. And just speaking about it, dystonia and Parkinsonism, they're treated with anticholinergics. But the committee or the advisory group really emphasized in the document the risks of not discontinuing oral anticholinergics in patients long after their symptoms have resolved. They often see patients that continue on this therapy indefinitely, and it poses a lot of risk for patients. The document also emphasizes akathisia as being commonly unrecognized by providers who mistake the signs and symptoms for agitation or anxiety, and they end up increasing the dose of the antipsychotic medication, which can end up worsening the akathisia, and that's takes a condition that's already very distressing for patients, and it usually can be a strong disincentive for patients to continue treatment. And then lastly, tardive dyskinesia, though it's less common now with second-generation medications, It can be irreversible despite modifying antipsychotic doses or regimens. And so the MCAG recommends using an informed consent process before starting antipsychotic medication in patients. The AIMS is the abnormal involuntary movement scale. You might be familiar with it when the P&T committee has reviewed the scale before. It can be used to accurately diagnose tardive dyskinesia and as well as assess ongoing symptoms. And those symptoms can really fluctuate over time and be modified by different stress factors. And then if tardive dyskinesia does advance to more mild, moderate or severe symptoms, the MCAG recommends starting medication with these two medications here, valbenazine or tetrabenazine, and those are called VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors, and this committee has reviewed those previously, I believe last year. And if those provide clinically meaningful improvement in symptoms and as assessed by using the AIMS, and those can be continued, should be continued. The next slide is chronic insomnia disorder. That was published last month, and obviously an important problem that requires intervention. And MCAG emphasized that if it's left untreated, the insomnia can really exacerbate co-occurring mental health disorders, and likewise, untreated mental health disorders can really exacerbate sleep disturbances. So they also highlight just the importance of differential diagnoses to create greater awareness for providers about why someone might be complaining about sleep problems. And they discuss sleep hygiene guidelines and emphasize that those alone are insufficient to manage chronic insomnia disorder, but can be a part of a larger treatment plan. And they like others, they state that cognitive behavioral therapy for insomnia is a first-line treatment option recommendation for insomnia disorder. It provides clinically meaningful long-term improvement in several key sleep outcomes, and it can also be tailored to match someone's clinical presentation and provides significant benefit in people with co-occurring mental health disorders. Obviously, treatment to cognitive behavioral therapy is correlated with efficacy, so it requires motivation and effort on part of the patient to change the behaviors and thinking patterns that they have that might be perpetuating insomnia. But the MCAG emphasizes the role of providers, that what they play in following up with patients and addressing adherence and really promoting patient motivation. So there are now several evidence-based online programs as well and apps that are designed as cognitive behavioral therapy for insomnia. And so the MCAG document lists several programs that are available with evidence and provides a few free ones that are provided by the VA. And the next slide, my last slide, if medications are used, the MCAG document highlights the recommendations for each drug commonly used for insomnia, including those that should be avoided. And they summarize the evidence for both efficacy and harms for each medication and try to provide helpful tips and warnings to consider when choosing medication. But they acknowledge that it's tempting for providers to resort to medications to manage insomnia, but they acknowledge that most of them have harmful long-term effects, and they do not facilitate restorative sleep. So while they can receive pressure from patients that it's easy to resort to a medication-first strategy, they emphasize a harm reduction approach to steer people away from chronic use of insomnia medications whenever possible. So thank you for your time. If you have any questions or suggestions for topics that the MCAG could take up, please email me. My email is on the MCAG website if you don't have it already, and appreciate your time. Thank you.
Thank you, Andrew. Any questions for Andrew? Very useful. So as I mentioned at the top of the order, the P&T committee also serves as a DUR board. DUR meetings are required to be held quarterly, so we focus one of our meetings each quarter on DUR activities. part of the consent agenda. The first topic is the quarterly utilization report. We present those during these DUR reports. The consent agenda also provides us an opportunity to cover quite a bit of information and use our policies without spending a lot of time presenting them. So we propose for the committee to approve the recommendations from the consent agenda topics, unless anybody wishes to pull those off for discussion. Hearing nobody want to pull those off, we'd need a motion to approve the recommendations to add the agents to oncology PA, the orphan drug policy, and to apply the drugs for unfunded conditions to the abbreviated drug review for Zelsuvmi.
To approve the consent agenda.
Thank you, Doug.
Second.
Second. 2 seconds. All right. All those in favor?
Aye.
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 Opposed? Abstain? Thank you. Motion carries.
Great. So as I mentioned, DUR, drug use review, is a focus of this meeting. So if you're following along in the packet of the materials posted on our website, draw your attention to page 31. We have our prospective DUR that's achieved by Gainwell Technologies on behalf of the OHA, and we'll turn it over to Lan Starkwell. Starkweather, sorry, Lan.
No worries.
Big superhero name.
Alrighty, so this is a high-level summary of the DUR activities for the quarter. Most of these alerts are set to informational. It'll still pay the claim, but allow the pharmacy to know the interaction. The 2 highlighted in yellow set to deny and require an intervention by the pharmacy or the pharmacist in order for it to pay. We had close to 104,000 early refill alerts hit the system for the quarter. 23,000 were overridden. So that's a 22.9% override. And then the other one also set to deny the claim is the pregnancy drug interaction. We had 21 total for the quarter, 18 overridden, so 85% override. Next page. Here is just a breakdown of the drugs that were enforced in early refill alerts. These are the mental health carve-out drugs. Majority of them were the antidepressants, so I've broken it up into the SSRIs in the top table, then all of the other antidepressants. Overall total for the class average is about 21% of the overrides. The antipsychotics also have a high number of alerts. This one had more percent override, close to 23% override total for the class itself. And then the last 2 tables are the anxiolytic and other carve-out drugs. Next page. This table shows the different reason code for the early refill overrides. Overall, we had an average of about 5,400 monthly average for the 3 months. 3.4% was due to a vacation supply. 5.2% lost medication, 13.9% was due to change in therapy, but a majority of the overrides was due to medically necessary, so 72.5% overrides. Next page. And then lastly, this is just a summary of the prescriptions that were not dispensed because of the because of the DUR alerts. For the month of April, we had 18, 171 for May, and then a high number, so 554 for June. And I believe this is mainly due to people are out of school and getting vacation overrides. Overall total in cost savings, 197,000 for OHA. Any questions on the DUR report?
Great, thank you, Lan. The next part of DUR is retrospective, retro-DUR. Page 35, we have the materials in our packet, and we'll turn it over to Dave Engen.
All right, thank you, Roger. Yeah, we're on page 35, and for the latest retro-DUR report, we're looking at Q3 data. So that's April through June of 2024. And I'll just hit the high points of this report. So on this page, you can see the initiative billing correction review. It's keeping track of high dollar claims that may have been billed incorrectly. We're still making tweaks to the report and the workflow since it's a new process, and it generally requires manual review and phone calls to the patient's primary insurer, possibly the pharmacy as well. So we'll keep you posted on the progress of this as we flesh everything out. Just for clarification, OCC, it stands for Other Coverage Code, and each of those numbers corresponds to a different messaging. So yeah, so on page 36, we see our change forms. There's a slowdown, it looks like, in opportunities for providers to change to a more cost-effective formulation. You can see aripiprazole. It's one of the more popular agents, and it's still generating about 14,000 in savings for Q3. And that number, as I've said, increases over time. But the desvenlafaxine and venlafaxine, they're essentially retired at this point. It's running in the background, but we'll keep looking for new opportunities and let you know on the progress of that. Page 37, that captures our messaging to prescribers about dose consolidation. Nothing too significant there, but once again, most of the messaging it's going on at point of sale now, but when appropriate, those messages do go out. So yeah, and page 38. That is our expert consultation referral. It's for long-term antipsychotic use in kids. There's lots of patients that are screened, you can see, but relatively few are flagged as really high risk. But those that are, prescribers get a referral to Opal K for a consult. And those are the numbers there. Page 39. That's our messaging to prescribers about patient non-adherence to their antipsychotics. We're still getting some traction on that and seeing patients refill their medication in the next 90 days after their prescriber was notified. Page 40, this lists the different individualized profile reviews for children in foster care, as well as for patients with a variety of high-risk conditions, so bipolar, polypharmacy, chronic opioids, and that those types. So those numbers, they're staying pretty consistent quarter by quarter, and we continue to message the prescribers whenever it's appropriate. Yeah, page 41. That's our safety net program for antipsychotics in really young children. Again, if we know PA is ending, we proactively notify the prescribers to submit a new PA for their patient. We tell them what's going to be required so the patients get the appropriate care with no interruption in therapy. And as before, those numbers are pretty consistent with previous quarters. And then on page 42, it's reporting the safety net monitoring. The first one's for patients on dangerous opioid sedative combos, and still about a third of those prescription combos are being discontinued within 3 months after notification. And that number fluctuates a little bit, but generally we're getting pretty good traction on that. Also, you can see there's a handful of prescribers being notified if their patient's been denied an oncology med and there's no evidence of a new fill for an alternative agent. Make sure that message gets out there. And then we do the same thing for prescribers whose pediatric patients were denied a TCA, but no alternative was filled or requested. And then we have, once again, similar numbers the previous quarter. So yeah, that's a summary of the RetroDur report. Once again, please let us know if you think of new opportunities or you hear of them in this space so we can investigate those new ideas. But yeah, if there's no other questions at this time, I'll turn it back over to Roger.
Thank you, Dave. Any questions on the RetroDur projects? All right, hearing none, we'll forge forward. So education is another component of DUR. One of the ways that we accomplish that is through our DUR newsletters, the Oregon State Drug Review. And Kathy Centena is our editor, and we'll go over a couple recent newsletters. If you're following along in the packet, the first one's going to start on page 43.
Great, thanks, Roger. Yeah, so today we will be recapping just a couple newsletters. The first one was posted in February, where we published a newsletter on Hep C care for primary care providers. This newsletter provides recommendations for screening, treatment, and monitoring of patients with Hep C, and also provides risk stratification for treatment in the primary care setting. The second newsletter was published in March, and it reports finding of an asthma relief inhaler drug use evaluation. This does start on page 47 in your packet if you're interested. This newsletter includes data related to the usage patterns of short-acting beta agonist inhalers in patients with and without asthma. Again, I'd like to thank the authors who assist in providing these important provider education pieces, and to the committee for providing feedback and suggestions for the newsletter. Speaking of that, at this time, if anybody has topics they think might be interesting to our providers, we'd love to hear them now, or you can always email us as well. And then, of course, you can sign up to receive our newsletters on our website if you'd like, to receive them electronically, that is. And I encourage you to take a look at our most recently posted newsletter on lifestyle modifications.
Awesome, Kathy. Thank you very much.
Mm-hmm.
All right. Next up, we're going to get into the start of our preferred drug list new business and some of our DUR activities. So turning your attention to page 50 in the packet of materials, and we have the Xolair PA update. I'm going to turn it over to Deanna.
Great. Thank you, Roger. Next slide, please. So the reason we're bringing this forward is because omalizumab or Xolair recently received an expanded FDA approval to reduce allergic reactions or anaphylaxis that might occur in people that have food allergies that generates an IgE-mediated response. So the purpose of this update is to review the evidence for the safety and efficacy of omalizumab in that particular indication. Next slide, please. Just a little background, food allergy affects 15 million people in the United States. The current treatment is to, one, avoid eating the foods that cause that allergic reaction, which can be difficult to control sometimes when people are eating in public areas and not eating at home. And also to have medications such as epinephrine on hand in case of a reaction. But we have reviewed Palforzia, which is the peanut allergen powder that is FDA approved just to desensitize patients with patient allergy. And the PA criteria for that is on page 70 of the packet in Appendix 2. The Oregon Health Plan, or OHP, prioritized list does include funding for peanut allergy treatment in Guideline Note 203. And currently, that guideline note says that the peanut allergy must be diagnosed based on a history of a serious reaction or anaphylaxis, along with skin or serologic testing, and also have a double-blind placebo-controlled oral food challenge test. And the treatment must be in consultation or prescribed by an allergist or an immunologist. Next slide, please. So omalizumab has been on the market for several years. It inhibits the binding of immunoglobulin E to the high affinity IgE receptors that are on the surface of mast cells and basophils, which downregulates the activity of those cells. The FDA-approved indications are quite wide. First, it's approved for moderate to severe persistent asthma. It also has the approval for chronic rhinosinusitis with nasal polyps, which is abbreviated as CRSwNP. It's also approved for treatment of chronic spontaneous urticaria and then also reduction of the food allergies. The only one that's not funded by the Health Evidence Review Commission or HERC is urticaria. Next slide, please. So the clinical efficacy of omalizumab for food allergies was conducted in a multi-center double-blind phase 3 randomized control trial that was placebo-controlled. They enrolled 165 adults and 3 children that ranged from age of 1 to 56. And they all had a peanut allergy, and then they also had to have an allergy to 2 other drugs that were included in the protocol. So either milk, wheat, cashew nuts, hazelnuts, or walnuts. And of note, soy and seafood were excluded. Those are 2 other food allergies that quite a few people have. The duration of the treatment was 16 to 20 weeks, and the patients were randomized 2 to 1, either to placebo or weight-based subcutaneous omalizumab. The primary outcome was the number of patients who successfully consumed peanut protein that was greater than 600 milligrams without having symptoms. And as you can see from the results there, 67% of the patients that received omalizumab had a positive outcome, compared with 7% of the placebo-treated patients. So that was considered statistically significant. Next slide, please. So some of the limitations for this trial, there were some clear treatment failures, and there was variability in the response rates. About 17% of patients did not respond that had peanut allergies, and those numbers went up with milk, egg, and cashew allergies. The numbers are there on the slide. And it is approved in pediatrics aged 1 year and over, but the trial only included 3 children. Their mean age was 8 years, and the range was 1 to 17. Next slide, please. So this is just a summary of the adverse reactions. Since omalizumab is administered by the subcutaneous route, it's not surprising that injection site reaction was one of the most prominent adverse reactions that occurred in 15% of the patients that received omalizumab. And then fever also occurred. Next slide, please. So I mentioned to you what the current guidance is on Guideline Note 203. We've been communicating with the Health Evidence Review Commission regarding that guideline note, and Ariel Smits, the HERC medical director, recently communicated to me that she is going to present these proposed changes at the August HERC meeting. So they're going to revise Guideline Note 203 to refer to all foods, not just peanuts. So anytime peanut appeared in this, she was replacing that with the word food. And I want to draw your attention to the criteria. So they are still wanting to make sure the patient has a clinical history of a serious food allergy with anaphylaxis, that the food allergy has been confirmed with an IgE or skin prick test, excuse me. And I want you to notice that number 3, the requirement for the double-blind placebo-controlled food challenge is being removed. The reason for that is Dr. Smits consulted with Dr. Yoshi. He's an OHSU allergist, and he reported that there are no allergists in Oregon that are doing the double-blind or the single-blind food challenges. So in the interest of improving access to people that might need these treatments, HERC decided that it would be best to remove this. This has not been reviewed by the HERC committee yet. It will be soon. And then finally, the treatment, it has to be prescribed by or in consultation with an allergist or immunologist. So the recommendations are to revise our PA criteria for the targeted immune modulators. And I didn't state it earlier, but omalizumab is a targeted immune modulator. And all those indications that I mentioned earlier are addressed in the TIMS for severe asthma and atopic dermatitis PA criteria. So we're going to revise that PA criteria to include the use of omalizumab for treatment of severe food allergies in patients at high risk. And then we would also like to remove the diagnostic requirement for a food challenge from our Xolair or omalizumab PA criteria that was in the packet, as well as the Palforzia PA criteria. So we'll go through the changes to the PA criteria, starting with the next slide. Thanks to the efforts of Sarah Servid, the PA criteria for this particular class of drugs has been consolidated from 33 questions into 17. So Appendix 1, which is on page 54, that outlines our proposed changes. For comparison, starting on page 61 in Appendix 2, that's when the original criteria are posted if you want to compare. But I'll just go through the changes real quickly so you have an idea of what's been changed. So the only change on this is just we're changing the table number. That's okay. Next slide. Thanks, Sarah. So for the table 1, this was previously listed as table 2. We moved it up to table 1 because we moved the question asking about FDA approved indication earlier in the assessment steps. And so you can see with the red there, we added the column for avoidance of food allergies, and we added omalizumab. We added that indication to omalizumab. Next slide, please. So table 2 was created basically just to streamline the questions, because we were asking all of these questions in different steps. So all of the questions about prior therapy were moved into this table. And then table 1 has been relabeled to be table 3, which is the maximum adult doses for inhaled corticosteroids, which is for the asthma assessment. We also removed 2 other tables. We removed the dosing table for the monoclonal antibodies that are used to treat the asthma phenotypes, and the Dupixent or dupilumab dosing table, just to make the PA process more streamlined. Next slide is table 4. So similar process for this table as table 2. We move multiple questions into one question that just refers to this table, which is basically an assessment of the disease severity. As you may know, HERC does not fund mild atopic dermatitis or some of the other mild conditions. So that's why we have the severity outlined here. Next slide. Let's see. So the biggest change for question 2 was we just renumbered the table. Question 4 is that standard EPSDT question that we asked for documentation of a condition, how severe the condition is in patients that are less than 21 years of age. And then question 5 is just referring to the renewal criteria. Next slide, please. This page just shows you the consolidation of all the questions. So question 7 consolidates all the appropriate specialist into one question. Question 8 refers to the newly created table 2 and 3. So looking at first line conventional therapy. As I mentioned, table 3 is the conventional corticosteroid dosing. And then question 9 is another consolidation question that puts the assessment of disease severity into table 4 instead of asking specific questions for each disease state. We could go to the next slide. On this one, the severe asthma assessment has been consolidated into tables 2 and 4. So really no changes here. Next slide. So question 14 was the biggest change. In the packet, we had added the diagnostic documentation for food allergy to be the IgE-mediated food allergy confirmed with skin testing. And based on the changes in the HERC guidance, we're going to remove the double-blind placebo-controlled oral food challenge. So we will just be looking for the skin testing to confirm that they have the the allergy. The other thing we did, if you're following along with the old criteria, is remove the baseline lab assessment, hepatic and renal function, and drug interaction assessment for aprocitenib. We decided those assessments should be completed by the specialist and the pharmacist dispensing the medication. So we removed those questions from the PA criteria. Next slide, please. So this is the renewal criteria. The only change for this was question 1 used to say is a request to renew therapy for atopic dermatitis. We broadened it to be inflammatory skin disease because Pergio nodularis is now approved for management with dupilumab. So we didn't make any other changes to the PA criteria. I know that was a lot to go through with the changes to our PA criteria, but I wanted to open it up to the P&T committee to see if they had any questions about either the evidence for the Xolair expanded indication or the changes that we're planning to make to the targeted immune modulators for asthma and atopic dermatitis.
Hey, this is a great job, you guys. I love getting down from 33 to 17 questions, and I'm sure that Lan and the Gainwell folks will appreciate that as well. And I don't think nothing gets lost. So it was a great consolidation. So thank you both for working on this.
Oh, well, thanks, Stacy. The credit goes to Sarah. She really put a lot of effort into consolidating this. So yeah, I agree. Nice team effort. Any other comments or questions? Okay, Roger, I believe we have some public comments, correct?
We do have public comment. First up is Steve Hall from Genentech. Steve, I've made you co-host. Are you able to unmute your line?
I just did. Can you hear me, Roger?
Hear you loud and clear. You're
Excellent.
familiar with the process, so I think you'll probably see my big timer on the screen.
You bet. I won't need much.
All right. Well, you've heard the changes we recommended. I think those probably see well, but the floor is yours.
Thanks. Appreciate the opportunity. I did intend to talk to the double-blinded oral food challenge, but that has already been done. The only thing I will add is I think I heard mention that there were 3 children in the trial. Actually, it was mostly children, fewer adults. So you might want to go back and check that. Other than that, thank you for your time, and we appreciate the changes you have made.
Thank you for that. I will go back and double check.
You bet.
Awesome. Thank you, Steve. Next, we have Jason Lindy with FAIR. I'll let you describe the organization you belong to and you're representing. Are you able to unmute your line, Jason?
Yes, I am, Roger. Thank you. Yeah, I'm Jason Lindy. Oh, sorry, Roger.
No, I was going to say the floor is yours. So loud and clear. Hear you loud and clear.
Yeah, thank you. Yeah, I'm Jason Lindy. I'm the Senior Vice President of Advocacy at FAIR, which is Food Allergy Research and Education. We're the nation's largest nonprofit dedicated to helping the more than 33 million Americans with life-threatening food allergies. So I had a long spiel as well, but it was really focused on double blind. I did want to emphasize a couple of things, though, in getting rid of that. We're very grateful for the dismissal of that requirement because that would have prevented Xolair from helping Oregon's more than 430,000 food allergy patients. So the one thing I do want to raise here is that research in 2018 and 2019, and it's in my comments, demonstrate that America's food allergy population is double that was reported to this committee. It is more than 33 million, and if you add Puerto Rico, we're up over 34 million. The CDC has mentioned that there's been a doubling of peanut and tree nut allergies, and many of you may now know, you may have seen the CNN story last year that there are now more adults than children with life-threatening peanut allergies. So I just want to commend the committee for its work on removing the double-blind oral food challenge. We thought that was going to be a real block for providing Xolair to the people who need it most, and we are grateful for your help on that. And with that, I'll wrap. Thank you.
Jason, appreciate you taking the time. Any questions from the committee for Jason? Fantastic. Again, thank you. Appreciate your time. Tracy, I made you a co-host. Are you able to unmute your line?
Can you hear me?
Hear you loud and clear, and the floor is yours.
All right. I wish I could abbreviate mine since it sounds like the plan is to remove the oral food challenge, but I haven't testified, so I'm hoping you'll just have patience and hear what I have to say because I think it's evidence about why you've made a good choice. My name's Tracy Leto. I'm a resident of Portland, Oregon. Learned about this opportunity to testify from FAIR. My younger daughter has anaphylactic food allergies to nuts and seeds. She was diagnosed at age 2. I also have a daughter with celiac disease, diagnosed at age 7. So as you can imagine, much of our parenting has been focused on diligently avoiding consumption or cross-contamination by foods that could cause harm or kill our children. But that cost of diligent has been great. Our inability to sort of, confirm that we always have safe access to food, especially outside the home, has resulted in lost social and learning experiences, a chronic level of background stress, and it's likely a contributor to my daughter's obsessive compulsive disorder and generalized anxiety disorder. Xolair could be an option to reduce that fear and risk for my younger daughter, who has food allergies and at a really critical time. She starts college this fall. She'll be far away from home, and it's the first time she's going to rely on other people besides her parents to safely feed her 3 meals a day. Many colleges have greatly improved their protocols to handle allergens, but with the volume of students that colleges feed, the turnover of kitchen staff, and the growing number of foods that can cause anaphylactic reactions, the risk is still really great for our kids. And people with food allergies will go to great lengths to ensure their own safety, but potentially consuming a food that can cause a life-threatening anaphylactic reaction, such as through an oral food challenge, is a step many people will not take. Even in trade for the potential of future safety that something like Xolair might provide. After a very bad experience with oral immunotherapy, my daughter would not take that risk. But if the only step to potentially accessing Xolair is skin testing, it's a real opportunity for her. So I'm asking, please remove the requirement of the double-blind, placebo-controlled food challenge. It is a significant psychological, logistical, and financial barrier to many children and adults with food allergies who desire a new level of physical and emotional safety and all the opportunities that safety brings. Thank you.
Thank you, Tracy. Appreciate your time. Does the committee have any questions for Tracy? Excellent. All right. If we can bring the recommendations back up. And just to recap, we're going to propose to revise the criteria for the TIMS for severe asthma and atopic dermatitis so that we can include omalizumab for the treatment of food allergies. And we're also going to remove that diagnostic requirement for the food challenge from the Xolair and Palforzia PA criteria. Any discussion from the committee?
I have a question. Can I see that specific criteria that you had revision of question 14? Okay. So I would say that clearly the oral food challenges have their place in very select cases, but not as a criteria here. I mean, they can, open, single, and double, whether or not they're available or not, have their place for very selected cases, but not in this setting. So the diagnosis of food allergy is really dependent upon careful history. And then that confirmation is with IgE testing and or skin testing, prick testing, non-intradermal. So I think that there are, I don't think that it's exclusively skin, although I do know that there's a lot of, as long as it's in the immunologist, allergist hands, they'll make the correct decision in terms of the diagnosis, the history, and then the interpretation of either the IgE or the skin testing. But I don't think that you have to have skin testing. I think that you can do in vitro. Oh, I'm sorry. So above it says asthma, positive skin test or in vitro. Whereas below, it only says skin testing.
Correct. So this is part of the consolidation. You know, we had separate questions for each one. So what we put here is if it's for eosinophil asthma, we're looking for the blood eosinophil count because omalizumab's approved for that. And then if it's IgE mediated asthma, we're looking for a positive skin test or reactivity to the allergen. And for the food allergy, we were just looking for the skin testing or skin prick testing to confirm that they have an allergy to that food.
Well, I would say that the two the line above applies to food allergy as well.
So you're suggesting adding the in vitro reactivity to food allergy also?
Correct. I mean, if
Okay.
and I say this with caution because I'm going to tell you, a lot of my primary care colleagues are just horrid in terms of they're over ordering this. They're not taking a good history. They're over diagnosing food. They're using it as screening tests. IgE screen or panels are horrendous for. I mean, it's notorious for being misapplied and misinterpreted. But we're gonna insist that it's the allergist or immunologist that are doing this, and that they will come up with that diagnosis correctly and apply the there are certain situations where skin testing isn't necessary and doesn't add to it, and certainly I don't think we actually should tell the allergist it has to be this. It could be either. So
I have just a quick follow-up question with that though. So, but we got this wording though, essentially from what the HERC is planning on doing. So does it make sense for us to put something different than what the HERC puts?
Well, again, they haven't taken any action yet, so
Okay.
I think let's go with the P&T committee's recommendations for appropriate treatment.
Got it.
And if something changes when they talk about it or come up with a guideline and it warrants us bringing the subject act, we can do that. Maybe even as a consent agenda if it's a minor tweak or clerical. But I think the criteria we have in front of you is our best effort to have appropriate treatment.
Yeah, no, that makes sense. And if that, I don't know anything about allergy testing. So if you can actually do some sort of in vitro testing and that makes sense, then I would have no problems adding that to that line. But I don't know enough about it to really have an opinion.
well, I would say yes.
Does anybody else have anybody have any concerns with doing that or any other opinions that we want to consider? Okay.
And I would just point out question 7 asks if it's being prescribed by an appropriate specialist. I kind of glossed over it real quick, but that is addressed earlier in the assessment. The specific specialist, depending on what the indication is.
Right.
All right, great discussion. So with that, do we have anybody that wants to make a motion to both update as we said, update the TIMS for severe asthma and atopic dermatitis, allergic reactions during the exposure, and then to remove the diagnostic requirement for the food allergen from the Xolair and Palforzia as amended?
Well, that's my motion with the
Yeah, I was
amendment.
going to say, yeah. Do we have a second?
Everybody's scrambling for their mute buttons. Thank you, Bridget.
Okay. All right. All those in favor?
Aye.
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 Anyone opposed? Abstain? All right. Motion as amended carries.
Great discussion. Thank you all very much. Thank you too for the people providing public comment, and the committee. As you were aware, I sent out the written testimony in advance. That was also published on our website and will remain out there with the packet of materials. So moving on in the packet, bring your attention to page 73 if you're following along for the packet online, and we'll turn it over to, I think, Sarah Fletcher. Are you leading off?
I am. Thank you, Roger. We're going to do a big topic now. It's non-alcoholic steatohepatitis and then the weight management drugs for that disease as well. And just to orient everyone, the plan is to give a background and the new drug evaluation on resmetirom, and then we'll have discussion about that without voting because these topics are interrelated. And then the evidence for the weight loss drugs in NASH, cardiovascular disease as follow-up from last meeting, more discussion, and then we have 2 public commenters before final discussion, and then we'll take motions for edits and any changes before voting on those criteria. So because it's kind of big, I wanted to orient everyone to the plan. Go to the next page. So we're going to start off with background of NASH and then resmetirom, or brand name Resdifra. The purpose of this is to provide a background on the diagnosis and management of non-alcoholic fatty liver disease, which has also a year ago been renamed to metabolic dysfunction-associated steatotic liver disease, and then to assess the safety and efficacy of resmetirom for NASH, which is also renamed and similarly defined as metabolic dysfunction-associated steatohepatitis, or MASH. I'm going to use NASH because that's what's in the FDA label, but I want to acknowledge that they're essentially interchangeable terms. For background, non-alcoholic fatty liver disease is a progressive liver disease that affects about 25% of people worldwide. It's diagnosed with a greater than 5% of hepatocytes with macrovesicular steatosis, which is infiltration of the fat into the cells, and it's occurring in the absence of ongoing or recent alcohol consumption. NASH occurs in about 12% of those who have non-alcoholic fatty liver disease. It's a subset, and it involves the addition of inflammation and hepatocyte injury. And then MASH is similarly defined, but it has at least 1 cardiometabolic risk factor of 5 defined risk factors with documented steatosis. And those 5 risk factors, there are other associated conditions like PCOS, but those 5 risk factors are increased BMI or waist circumference, type 2 diabetes, hypertension, hypertriglyceridemia, and a decreased HDL. And I have diabetes and obesity with asterisks there because they're most associated with disease progression. So moving through fibrosis to cirrhosis to hepatocellular carcinoma. So they're the most important of the risk factors. And then also non-alcoholic fatty liver disease can occur in the absence of overweight or obesity. It's called lean fatty liver disease. And it's estimated about 4.1% in the US, but 19% in Asia. So there is ethnic differences there. If you go to the next slide, I just want to note that there are a multitude of different guidelines. The 2 at the top from the American Association of Clinical Endocrinology and then the European ones are the most up-to-date that have methods that were described and recommendations that were graded. And so I preferentially used those. We also consider NASH at the bottom a trusted source, but it's a little bit out of date. So I didn't reference that much. And there is more information in the packet in one of the appendices if you're curious. If you go to the next slide. So generally, diagnosis, staging, and assessment. If a patient's been has been identified as at risk for fatty liver disease, perhaps there was an incidental finding of something on imaging, increased liver enzymes without a cause, lots of risk factors. The preliminary assessment is usually non-invasive with something called a FIB-4 test, which is validated to predict changes over time in hepatic fibrosis, and it has good specificity and a negative predictive value to rule out advanced fibrosis. And that's fibrosis generally for steatotic changes. I'm not specifically talking about NASH. If that's an intermediate or high score, patients can be referred to additional imaging with a VCTE, which is the best validated, or an MRE, which is probably the most accurate. If those imagings are unavailable, there is a blood test called the ELF test, which can be used to also identify more advanced fibrotic disease. Now, the gold standard for definitive diagnosis is a biopsy. The European guidelines state that no non-invasive methods can assess relevant microscopic features of non-alcoholic fatty liver disease, such as ballooning or lobular inflammation. Liver biopsy is not required for the management, but is still required for definitive diagnosis of steatohepatitis and to rule out other causes. And then it's generally not appropriate for monitoring disease change over time due to the invasiveness, other than for specific cases or clinical trials. Now, if you go to the next page, these are some of the other causes of hepatosteatosis, in addition to non-alcoholic fatty liver disease. I'll note that alcohol-induced and fatty liver disease are the most common causes. These are more rare. If you go to the next page, once you have a diagnosis, NASH can be staged. It can present with no fibrosis or any of the 4 stages listed on the left. The natural progression from one stage to another is about 7 years, though that can change or be different based off of a person's genetics or which risk factors they have. I mentioned that diabetes and obesity are more associated with progression. And then on the right, you can see the non-alcoholic fatty liver disease activity score. I'll probably call it the activity score when we go through the trials. It has 3 components: the steatosis, inflammation, and ballooning. The composite score ranges from 0 to 8, and higher scores are more severe disease. This is used in clinical trials, and it's mandated by the FDA. It's not something that's used in clinical practice because it requires repeat histology, so repeat biopsy, to be able to see differences over time. And if you go to the next slide. The drug that I'm going to go over is the first drug that's approved specifically for liver-targeted therapy of NASH. So these are other treatments that are recommended in the guidelines for caring for a patient that has NASH in addition to other things. So cardiovascular risk management is one of the backbones. You can see the risks listed above. And I want to note that many of these pharmacologic therapies have outcomes data for things like heart attacks, stroke, mortality. And while patients who have NASH often have liver-related complications, they're also at high risk of cardiovascular disease. And a lot of patients have more problems with that, or as many problems with that as the liver. So that's to treat the whole patient, that is important. Specifically related to diabetes, I've got type 2 diabetes down there. Historically, pioglitazone has shown some evidence for efficacy in patients who have NASH. But the evidence is mixed. It can cause worsening heart failure or increased weight gain. And so recommendations for that are mixed in the guidelines. Patients who have diabetes and NASH are recommended to have GLPs and SGLT2 inhibitors for the cardiometabolic effects. And the GLPs may have some effect on the liver disease as well. And I'll go over that in more detail in a second. For vitamin E, high-dose vitamin E has also historically been offered as a treatment, but the data on that is mixed as well, and there's some drawbacks. And then weight loss through lifestyle changes can reduce or eliminate this disease in some ways. You can see weight loss of more than 10% can improve fibrosis and may reverse steatohepatitis. The lifestyle recommendations are recommended for all, and then pharmacologic augmentation is recommended for those who have non-alcoholic fatty liver disease, NASH, and concomitant obesity. I'll talk about that more in detail in the second section. And then some patients are treated with bariatric surgery, and that can resolve the NASH as well. We go to the next slide. This is resmetirom, which is the first drug approved specifically for treatment of NASH. It's a partial agonist of the thyroid hormone receptor beta. It was approved in March, indicated in conjunction with diet and exercise for adults with NASH in stage 2 or 3 fibrosis. It was through the accelerated approval pathway, so it's based on histology, and there's a continued approval is contingent on the verification and description of clinical benefits, such as death, liver transplantation, hepatic decompensation events, and confirmatory trials. And I want to mention that because drugs that have been approved through this pathway, about half of them meet their confirmatory endpoints. So we're looking at that or waiting for that very anxiously. And I want to note that this is just a once daily tablet. It's very easy administration. Next slide. Go back one. Okay. This drug was approved by the MAESTRO-NASH, which is a double-blind, placebo-controlled randomized trial with some stratification by presence or absence of diabetes and fibrosis stage. Had 2 different doses of resmetirom or placebo. 955 patients had paired biopsies. The total population was 966. Some patients weren't able to get the second biopsy because of COVID. Demographics were generally mid-50s. About 90% of patients were white. The median BMI was 35. 67% had type 2 diabetes. And that a non-alcoholic fatty liver disease activity score that ranged from 0 to 8, 83% had a 5 or greater. And then most of the patients, 62%, had a phase of fibrosis stage 3. Inclusion was 3 of the 5 metabolic risk factors that I listed at the beginning. There was imaging required with some very specific parameters that are in the packet, and then biopsy confirmed NASH. And then at minimum, patients had to have an activity score of 4 or more with at least one in each of those 3 components. And then patients with an A1C of more than 9% were excluded, as well as those with alcohol use. And this was done over 1 year with an ongoing trial for 54 months planned. Now, next page. So there were 2 primary outcomes. The first one was NASH resolution at week 52, and that was where the activity score had a 0 for the ballooning subcomponent, a 0 to 1 for the inflammation, and then a total reduction of at least 2 points out of that 8-point scale. So you can see 25.9 and 29.9% of resmetirom patients met that outcome, less than 10% for placebo, and those were statistically significant. The other primary outcome was the reverse, which was improvement in fibrosis by week 52 without a worsening of the NAS score. And so that was occurred in 24.2 and 25.9% of resmetirom treated patients and 14% of placebo. It was also statistically significant. There's no effect on body weight in either direction. And then the European guideline, which just came out in June, so it's the most recent, did state that it should be considered as a MASH targeted therapy in line with the local approved labeling for significant fibrosis that is not cirrhotic. So if you move to the next slide. So trial limitations, it was generally low risk of bias. There were some slight baseline imbalances. About 25% of the 100 milligram resmetirom group was Hispanic and 16% in placebo. The NAS score of more than 5 was 89% for that higher dose resmetirom group versus 10% less or 79% for the placebo group. Attrition was also higher in the drug groups at 17 to 22% versus 12% for placebo. The outcomes data are histologic improvement while we await the clinical data and potentially comparison with other treatments such as aggressive weight management. The durability of response and long-term data are unknown, and the population was limited to those with relatively well-controlled type 2 diabetes, so a hemoglobin A1C of 9 or less. And so we're not sure what the response would be for those who have less control, or where the disease is less fully controlled. And then it was a primarily white study population, about 90%, and that's not representative of those who are affected by these metabolic risk factors. Next slide. The big takeaway from safety, there weren't any major signs that I should bring up, but there are some drug interactions that require dose adjustments of statins. And then there was a lot of diarrhea that has been seen in this trial and in a different study that was only safety related that's in your packet. You can see 27 and 33% versus 15 for placebo. The duration was 2 to 3 weeks, and about 7% or 6.8% of that 100 milligram group discontinued specifically because of the diarrhea. We go to the next slide. I'm going to go through the PA criteria as proposed. It's for adults over 18. And then at question 4, we do ask for a liver biopsy at some point in the lifetime to clarify the diagnosis. But staging in question 5 can be done via that biopsy or some of the other tests that I mentioned that are less invasive. Question 6 has restriction to a hepatologist or a gastroenterologist. Question 7. Will the patient be engaged in a weight management lifestyle program? That is part of the labeling. It's part of the labeling on the FDA. And then number 9 is where we start to talk about some of these comorbidities. Does the patient have the hypertension, dyslipidemia, or overweight or obesity? And if so, we are asking in question 9 that there be some treatment addressment of those. My goal was not to be too restrictive, such as requiring max dose statin or multiple antihypertensives, but we do want to know that these are being treated because they are related to worsening this disease, as well as they have outcomes data for the diseases as well. So treating someone for dyslipidemia with a statin can reduce their risk of heart attack, and we know that versus histology. And what is in red right now, that is dependent on the next section that I'm going to go through. So if you go to the next slide, it's the same as the others as far as asking about comorbidities. If the patient does not have diabetes, have been screened, because about 2/3 of patients with NASH have concomitant type 2 diabetes. And then if so, is the patient prescribed metformin, GLPs, and an SGLT2 inhibitor if they are not currently controlled with their A1C? And that's in line with some of the guidelines that I'm going to present later. The GLPs and the SGLT2s have cardiometabolic effects for type 2 diabetics. The GLPs may also affect the liver. I'll go into that in more detail in a second. So if we go to the next slide, this is the renewal criteria. We have an attestation that the patient is continuing the treatments for comorbidities and lifestyle therapy. We're not going to check that. We're just asking for an attestation. And number 2, also attestation that the patient is taking this resmetirom, or if we can check from claims history, we would take that as well, because we can see claims history on that medication. Number 3, has the patient had a metabolic panel of liver enzymes or some other appropriate biochemical or non-invasive imaging to assess disease progression? That is, as we'll get to one of the later stages, it's not approved in stage 4, and so we want to make sure that the patients are being assessed for progression of this disease while on resmetirom. Question 4, So 3 offered biochemical test. Question 4 is, has it been 3 years or more since having a more an imaging test where you can more clearly see, or a repeat biopsy only if that was necessary, but an imaging test. And then question 5, does the patient have stage 4 fibrosis for which this drug is not approved, or is it worsening? So if a patient was stage 2 and they've already moved to stage 3, is it appropriate to continue this medication based off of the outcomes of it reversing fibrosis? And then question 6 is there documentation of a risk-benefit assessment for the ongoing treatment with possible resolution of metabolic comorbidities? The thought behind that question is if a patient does have lifestyle changes or some other therapy where obesity has resolved, or they're no longer requiring medications for type 2 diabetes or their hypertension, then is it appropriate to continue this for NASH? If that hasn't happened, then obviously the risk-benefit assessment would be to continue, but we just wanted to ask that question. So if we move to the next slide, I want to open this up to discussion, and I specifically would like some committee input on the biopsy requirement. I've said what the guidelines have said. Also, other organizations such as the VA do require a biopsy. We have internally spoken with a hepatologist who works with these patients who did say that often patients do not have biopsies if other things have been ruled out adequately, and it might create a barrier to care. And so I want you all to weigh that. Also, the comorbidity treatment. I've listed requirements for comorbidity treatment because we have outcomes data versus the accelerated approval. I want your thoughts on that. And then the renewal criteria. And so the recommendations are for the PA for resmetirom. We're going to take motions for changes and voting at the end, but I want a discussion now.
I'm not in favor of requiring a biopsy. As long as the specialist has done alternative testing and is assured that that's what they're treating. I think the comorbidity treatment is appropriate, but you need to go with the proven drugs, the proven approaches, and I'm okay on renewal as well.
Yeah, I think there's going to have to be some sort of wiggle room with the biopsy. Just thinking about how difficult is it to be able to get a biopsy? Is that going to delay treatment? And I think that without the biopsy, with the imaging and the FIB-4 score and all of that, you can get pretty close without having to do the biopsy. I mean, I don't think we want to discourage it if it's available, but I also don't think we want to make it a barrier. So we may want to put some language in there that, biopsy is preferred, but alternatively, if there is a documented reason why that can't happen, that doesn't stop the PA process. And I'm not sure exactly how to word that, but that's kind of my thought. And then, yeah, I'm fine with the comorbidity treatment and the renewal criteria.
Would you, just to think about for the last discussion, would you think of the dropping the biopsy, including ruling out other causes and having 1 of the 5, or as the trial did, 3 of the 5 metabolic comorbidities as the bypass? And that can be more for the discussion, but just to float that out there.
Yeah, I like that a lot. And I actually would go with the 3 comorbidities. I mean, yeah, so I would lean towards that. I think that's a great compromise.
Okay. Anybody else before we go on? And we'll bring this back before we make actual changes at the end, but we'll make sure that we can address any changes then. Okay, Sarah, can you go to the next slide? So I'm going to shift gears and I'm going to go over evidence for the GLPs or the dual GIPs, which I'll just refer to as GLPs, and their evidence for use in NASH. You go to the next slide. The purpose of this is to assess, and this is the 3rd time we've brought this class to the committee, so I think you've seen some of this before, but to assess the off-label compendia use of specific weight loss drugs in NASH. Currently, drugs for weight loss are excluded by the Oregon State Plan. I know this committee has recommended that we identify a funding plan to cover drugs when prescribed for weight management. When they're prescribed for other indications than weight loss, they're required to be covered if there's sufficient evidence for safety and efficacy. And that can be limited to medically appropriate use, such as an FDA approval, like with the cardiovascular outcomes, or compendia-supported indications. Now, currently, semaglutide and liraglutide have compendia support. There are 3 compendia. One of them is Micromedex, and that's where it is for use in NASH in adults with overweight or obesity. Both of them have a 2B recommendation, which means recommended in some cases. The strength of evidence rating for semaglutide is a B out of an A through D scale and is an A for liraglutide. And then an update to the Medicaid state plan is not required for coverage of compendia supported indications. So that's the background for this. If you go to the next slide, this is where I'm going to go more in detail on what those guidelines said related to GLP use in patients who have NASH. So when not effectively, weight loss when not effectively achieved by lifestyle interventions, pharmacotherapeutic augmentation is recommended for those with fatty liver disease or NASH and concomitant obesity or overweight with a BMI of greater than 27. Also, histologic benefit could be expected if substantial weight loss is induced by the GLPs, but it has not yet been extensively documented. They're safe for use in NASH, including cirrhosis, and are recommended for use with the indications of type 2 diabetes and obesity due to the cardiometabolic effect. And then obesity pharmacotherapy as adjunctive to lifestyle for individuals who have obesity and not fatty liver disease or NASH can promote cardiometabolic health. And it's used to treat type 2 diabetes, cardiovascular disease, and other end-stage manifestations must be considered. The role of GLPs in those who do not have overweight or type 2 diabetes is undefined and requires additional data. So that would be a setting of lean non-alcoholic fatty liver disease. If you go to the next slide, the previous slide was specific to adults. For pediatrics, the treatment focus is for lifestyle changes, and GLPs for pediatrics who have type 2 diabetes and obesity can be considered, but that is based on a grade D expert opinion rating. And so I'm primarily in the rest of this talking about adults. Go to the next slide. I've included in the packet in one of the appendix several phase 2 studies. I was limiting it to placebo-controlled with histologic endpoints so that it would be more comparable to what we were talking about elsewhere. There are other studies with either concomitant use with metformin or other endpoints that I did not include, but are taken into account by the compendia. So first off, there's a study by for liraglutide. It's from 2016, and it only had 52 patients in it. I want to note that NASH was defined as definite NASH. I think there's been some changes in the nomenclature and terminology around this. And patients had with or without type 2 diabetes. They did exclude patients with an A1C of more than 9%. You can see that the endpoint was the disappearance of steatohepatitis and no worsening of fibrosis. And so the improvement of liver histology at week 48 was achieved in 39% of patients. That was found to be statistically significant. If you go to the next slide, this is the first of 2 with semaglutide. This one, I want the takeaway to be, so it was 2.4 milligram semaglutide, but the population was those who had cirrhosis. So they had fibrosis stage 4, and the improvement of liver fibrosis and the secondary endpoint of resolution of NASH were not significant. So it did not work in patients who had stage 4 fibrosis. And over in the notes section, there were more hepatic adverse events. They were mild to moderate. There were more in the semaglutide group versus the placebo group. If you go to the next slide, this is a different phase 2 semaglutide study. There's a phase 3 one in process. First, note the doses. These are daily sub-Q doses and doses that we do not currently have on the market. 0.4 daily is equal to 2.8 a week. And then versus placebo. This had over 300 patients, so it was fairly large for a phase 2 study. And you can see in the inclusion criteria, the stage 1, 2, or 3 fibrosis, though the main outcomes, the primary outcomes were only stage 2 and 3. And then exclusion also included A1C of more than 10%. On the outcomes, you can see that the NASH resolution with no worsening of fibrosis, which is similar to what we had seen with some of the previous studies, had between 36 and 59% with the semaglutide treated patients versus 17% with placebo. There was no dose response, interestingly. And then the second primary endpoint, improvement of at least 1 fibrosis stage, was not significant. The placebo group had a 33% improvement. And then anecdotally at the bottom of that column, you can see worsening of fibrosis. So the reverse of that non-significant endpoint. There was more worsening of fibrosis with the placebo group, but that was just pulled out of the study. It was not an endpoint. I just thought that it was worth noting. The weight loss achieved in these patients ranged from 4.84% to 12.5% in those 3 different groups and was less than 1% in the placebo group. And now if you go to the next slide, This is tirzepatide. It does not have compendia support yet, but this study was published about 2 months ago, so I have been watching for it. You can see the Synergy NASH study had 3 different doses of tirzepatide. It was 190 patients and it lasted 52 weeks. Not all of those 190 patients had the repeat biopsy to be in the final endpoint. 157 met that. Stage 2 and 3 MASH and patients with an A1C of 9.5% or more were excluded. You can see that primary endpoint of resolution of MASH without worsening of fibrosis at week 52 ranged between 44 and 62% in the treatment groups and 10% in the placebo group. And then the improvement of at least one fibrosis stage, the one that was not statistically significant with semaglutide, does come out as statistically significant here based off of those confidence intervals. So about half of the patients did achieve that endpoint. Weight loss for these groups ranged between 10.7 to 15.6% versus less than 1% in the placebo group. And so now if you'll go to the next slide, I'll turn it over to Sarah for a second.
Yeah, thanks. I'm going to shift gears a little bit and stick with semaglutide, but talk a little bit about cardiovascular prevention. This is a topic that was discussed at the last PNT meeting, but there was a lot of discussion around it and wanted to bring back a little bit more evidence after looking into it more for your consideration. And we're going to be specifically focusing on evidence of recurrent cardiovascular events in people less than 45 years of age. Just as a reminder, semaglutide does have a variety of indications, so it's approved for type 2 diabetes. It also has evidence for cardiovascular risk reduction in people with type 2 diabetes who have established cardiovascular disease, who have already had a cardiovascular event. It's also indicated for reduction of weight management, which is not currently covered, as Sarah mentioned, under the state plan, but also has the indication to reduce cardiovascular events in adults with established cardiovascular disease who are also overweight. And that population and indication is covered currently. The current PA criteria approved by the committee at the last meeting does limit that last indication to people who are over 45 years of age. And that was based on primarily because that population was excluded from the SELECT trial, which was discussed at the last meeting. But I wanted to bring forward and talk about a little bit the risk assessment and guideline recommendations around this population. So as most people probably know, there are a variety of risk factors for cardiovascular disease, and that does include obesity and some related conditions such as like waist to hip ratio, dietary patterns, and physical inactivity. Guidelines do recommend risk assessment to quantify risk of major adverse cardiovascular events for people. High-risk groups are generally defined as having more than a 10-year risk of major adverse cardiovascular event over a 10-year period. And the guidelines split recommendations into primary prevention and secondary prevention. So people who have already had a cardiovascular event, such as a heart attack or stroke, are generally classified as having high risk for recurrent events. So over that 10% threshold for another event over 10 years. And magnitude of risk does vary substantially depending on the type of cardiovascular disease, and the number and severity of comorbid factors that an individual patient has. So the American Heart Association recommends risk stratification for people who have already had a cardiovascular event into low, intermediate, or high annual risk of death or non-fatal MI. And so that low risk group is less than 1% per year, so corresponding about to that 10% risk over a 10-year period. Intermediate 1 to 3% annual risk, and high risk groups are greater than 3% annual risk, or an estimated risk of over 30% over 10 years. And just this is detailed further in the packet, but there are guidelines for chronic coronary artery disease that are put out there and define who have individuals who probably have very high risk of recurrent events. And there are several scoring tools that have also been validated in this population in people with established cardiovascular disease. And those are outlined in your packet as well. So in looking at young people who have cardiovascular disease, so specifically people who are less than 45 years of age, observational studies and guidelines highlight that obesity is also a risk factor for cardiovascular events in this population, as well as physical inactivity. So that's similar no matter what age you are. In young people, substance use disorders and systemic inflammatory disorders also have a higher prevalence in people with cardiovascular disease. So those are probably larger contributor for cardiovascular risk in young people. And then also psychosocial factors are highlighted as a risk in young people. We do have limited data from observational studies that indicate people with premature cardiovascular disease, so have a cardiovascular event at less than 45 years of age, have a similar risk for recurrent cardiovascular events as older populations. And so the American Heart Association does recommend use of guideline-directed therapy to manage those risk factors, no matter what age people are. And in people who are living with overweight or obesity, this does include counseling on diet, lifestyle changes, and management of goals around the diet and lifestyle. And then if an individual needs further weight reduction, in addition, after they've made those changes, they do recommend a GLP-1 receptor agonist if further weight reduction is needed. And they prefer semaglutide over liraglutide because semaglutide has some of those cardiovascular events and is associated with more weight loss than liraglutide generally. Guidelines from NICE have similar recommendations for weight management in people who have cardiovascular disease as well. And so these are recommendations that we're putting forward for GLP-1 arrays, and I'll shift over to the PA criteria in a second. But based on the evidence that Sarah presented in NASH, consider adding coverage of specific GLP-1 RAs with compendia support for treatment of NASH in adults who are overweight or have obesity. And then also removing age restrictions for semaglutide in people with established cardiovascular disease who are overweight or have obesity, because this population is at increased risk of recurrent cardiovascular events that's independent of age. Give me a second to pull up the PA criteria. And Sarah, did you want to talk through these?
Sure. All right, everyone, it was so long we were going to move to the packet instead of having them in slides. So the updates to this PA, you can see in the goals the addition of NASH or MASH. You scroll down. We also have an additional table to consider. Currently, liraglutide and semaglutide are the two that do have compendia support. We could, if this is approved, we could add tirzepatide if it does receive compendia support. Things to think about. This also says biopsy confirmed. If that is changed to the other one, we might consider if we want to do the same or similar here. And then the compendia just specify NASH based off of the evidence. Most of it was in 2 and 3 stage fibrosis. And so that's also something to consider if we wanted to add it. If you scroll down, I think 3 and 4 are basically clerical edits to improve the flow when we were trying to add this additional indication. Question 5 is related to the ages that Sarah has been discussing as far as cardiovascular. And then if you continue to scroll, so question 5 would skip the setmelanotide and we go down to number 9. Does the patient have any comorbidities? We've added fatty liver disease as a comorbidity. And then, let's see, 10 is the same. 11 and 12, those were where we had reworded or reorganized the order. And then number 11, sorry, I want to call it number 11. It's hard to see, is a request for FDA approved or compendia supported request as defined in table 3. Table 3 was the one above that has liraglutide and semaglutide for NASH and or CV disease. And so those are the changes. I don't think there are any other non-clerical changes below, other than is the patient willing to try semaglutide for at least 4 months? I think that was the titration. Is there anything else, Sarah, related to yours? I think those are essentially the NASH changes. And then in the
there is just a minor change for the criteria that we have for the CLIP receptor agonist for diabetes, just pointing people to the weight management criteria if the patient has one of those compendia supported indications, so that they have a pathway to approval for those indications.
I have a couple of quick questions when you guys are ready to take them.
Absolutely.
Okay. So my first question is, with the dosing from the studies, are we concerned that Ozempic is not available in that dosing? So really, if we're looking at the 2.4 milligrams weekly, that's only going to be Wegovy, right? So if the approval is for Ozempic, and I'm not saying we need to change it, it was just something to think about. So the dosing we're approving won't exactly match what they studied.
Are we talking about the NASH where it had the daily sub-Q dosing?
Well, or even the 2.4 milligram weekly.
For the 2.4 as it's currently written, you would start with the Ozempic and you could get to the max 2 milligram dose and then switch to Wegovy.
Okay,
and that was that was the thought from the last meeting. So
Perfect. No, that makes
that
sense.
was cost related.
Yeah. And then one other question about the tirzepatide. It's my recollection, and this may have changed, that they're limiting use only to type 2 diabetes. So if we're approving this for someone that doesn't have diabetes, but has NASH or MASH or whatever we're calling it, I just am wondering, like, has that changed? And do we need to be worried about it at this point? Because we're really leaning more towards semaglutide and liraglutide over the tirzepatide initially, right?
Well, currently tirzepatide doesn't even have the compendia because the study only came out 2 months ago. I would, if it did get it and we voted to include NASH and MASH in this, it would be added. What is the work you said it's not being used for anything other than diabetes? Are you talking about OHA policy specifically? Or
no, I'm talking about like the manufacturer sent notices, which again may have changed, but I don't think so, to restrict use of Mounjaro to type 2 diabetes. So not to use it for weight loss or other comorbidities. So I just don't want to approve something that then the manufacturer says, oh, hey, you shouldn't be. And I know they're not necessarily, I know that's a behind the scenes kind of thing, but just something to think about as we move forward. If we're talking about tirzepatide, we just want to make sure that there aren't restrictions from the manufacturer or recommended restrictions in terms of who can be on it.
That's great information. I didn't know any of that. We could, before clerically adding it, assuming it gets the compendia, we can look into that more closely.
If I may, I'm pretty sure that tirzepatide has the Zepbound iteration, which is marketed for weight loss as the Wegovy versus Ozempic kind of pairing.
Yeah, exactly. So yeah, I mean, we would just, we would just need to kind of keep that in mind. But you're right, the Zepbound does, but just Mounjaro, which is the one that I think the studies were done on, that one is the one that the manufacturer has, reminded us not to use for anything other than type 2 diabetes.
Got it.
And I think one thing to consider, because this criteria as written would be approving the tirzepatide in someone with NASH who also has obesity or overweight. And so I think it might be able to be easier to get Zepbound in that
Yes.
circumstance because they have the comorbid condition.
Right. Yeah.
Other questions? Good discussion.
I have a question, and maybe this, I think, to clarify, with this PA criteria, are we steering people towards Ozempic for weight loss?
We are doing that titration period, yes.
Okay.
Or
And-
cardiovascular risk reduction.
Yes. Or sorry, yes, cardiovascular risk reduction. Has there been any discussion or concern about contributing to the shortage of these agents than for type 2 diabetes, which is the current issue with Ozempic and sometimes, and to Stacy's point, with Mounjaro, and why the drug manufacturers have come out with those letters, is because then patients with type 2 diabetes have not been able to get these products because they have been used for weight loss instead of the branded products, Wegovy and Zepbound.
That is certainly worth discussing. The recommendation for using Ozempic over Wegovy was based on costs because Ozempic is substantially cheaper for Medicaid, but yeah, you do have to factor in access. So if that's a substantial concern, we can change the criteria or put something in the criteria that that tries to address that circumstance.
Yeah, and I can see this kind of going both ways. If you look at the number of people who could use these agents for weight loss with one of these comorbid conditions, I'm guessing that number might be pretty high. But that doesn't necessarily mean that we're going to get PA requests for it, right? It doesn't mean that everybody who qualifies is necessarily going to use it. So this may be one of those times where we may want to move forward with a plan with the idea that, we may need to reevaluate in 6 months if we find that there's an overwhelming demand that might be negatively impacting other patients. So I think we try it, but I also think we need to, keep a pretty close eye on what the numbers look like and whether or not that's impacting the patients with type 2 diabetes who are relying on these agents for A1C control.
I think that's reasonable, Stacy, but I think you bring forward a good point, and just monitoring that as well is vital.
This is Eddie. Does anything in the PA criteria require for semaglutide in NASH? Does it require GI specialist or hepatologist prescribing, similar to the other drug that we discussed previously?
It does not, but we could add those restrictions in if that's an edit that we would like to make. I think we should also probably restrict it to just fibrosis 2 and 3. So I think there's some potential edits that could be added.
I was thinking about that, especially if we're considering removing the biopsy requirement for the semaglutide as well. Having the specialist prescriber would, potentially compensate for that because they're making that determination in the best way that they can.
In reality, though, how often are we referring patients to hepatology for NASH?
That's true.
I'm guessing not very often. Again, just based on my, our practice site, that would not be something that in our area we would refer out. I mean, maybe when they got to stage 4, or if there were other comorbidities or a question about the diagnosis. But outside of that, I would bet that most of the NASH patients are going to be managed through primary care providers. But again, maybe I'm wrong on that. But I would say probably I don't want to put the in consultation.
Yeah, no, that's a good point.
Those are great points. And I think if any changes we make, we probably should consider making sure that there's some alignment, particularly considering one is compendia and phase 2 trials, and one is based off evidence of a larger phase 3 trial. So I think in the final discussion, I think those are great points that we need to align between the criteria.
Other questions or discussion? We do have public comment.
Any discussion around removal of the age restriction for people with cardiovascular disease who are under 45? I know at the last meeting, the committee voted to restrict it to people over 45. With this new evidence on risk assessment in younger populations, is there any discussion around that from the committee?
I would like to acknowledge that I was part of making sure the recommendations were followed at last meeting, but I feel good about the review and would like to drop that age requirement.
Yeah, I agree.
Appreciate that, Doug and Stacy. All right, are we ready for public comment?
I have a question. This is Erica.
Yeah, Erica.
Resmetirom. Are we still talking about this one? Is it okay to ask question on this one?
Of course, it's kind of these
Oh.
blend together, so please go
Okay.
ahead.
Well, so that under the approval criteria of just a behavioral, isn't it? Like, were there like a behavioral change, weight management and lifestyle modification? And I was just wondering about, are we like specifically ask more like criteria regarding what is lifestyle modification? I just wanted to ask or add, if somebody who has NASH and still drinking and still are we gonna give medication? You know, it's just like, I feel like that should be kind of clarified.
It's a great
About alcohol.
question. As far as alcohol, they shouldn't be getting this for alcoholic-related steatohepatitis. This should be patients who do not have concomitant alcohol. That's part of the diagnostic criteria as far as biopsy or ruling out other causes. Does that answer that part of the question? And
Well, but you know, steatosis, it's hard to sometimes differentiate from alcohol, and probably both people could be drinking as well as have NASH, diabetes, obesity. And so I just feel like you know, when somebody's drinking a lot, but also have obesity and diabetes, when we can't tell the difference. I'm not excluding those people. I'm just saying, like, I want to make sure that that person will be strictly educated and agree upon when these medications are offered, which is expensive. So make sure that communication happen, and then how we going to monitor that. Just wanting to point out, because we, you know, I learned that resources are limited. We're not able to give all the medication to everybody. So if we, you know, if somebody is being provided this expensive medication, which is great, at the same time, I just want to make sure that they're also doing their part and stopping drinking if they are drinking some.
That's there are with the new nomenclature with MASH and the metabolic dysfunction, there is actually a new category that's MET ALD, so it's concomitant of both of them. So that is a valid point. Some patients could have a mixed picture. If we need to add something, I think I need to think about how we might want to add that. I'm not sure exactly what was done when the HIV drugs came out, and I know that that was a topic there as well, and I'm not sure if there was inclusion of restrictions or for abstinence. As far as the weight lifestyle programs, I'll say that the study was basically sending newsletters and doing a checklist. It wasn't a super involved weight management lifestyle program, but happy to hear other comments as well, especially based off of how this was handled when the direct acting antivirals came out for patients who had fibrosis related to hepatitis C.
That was a long time ago, but
That was, and we skirted around and talked about that. But by the same
It was
token,
before my time.
yeah, but people were also, while they might be injecting, if they were getting treatment for hepatitis, then they were more inclined to get off of the injectable drugs,
right,
because of the positive influence on their, progress. So it's kind of a slippery slope. I mean, I want to acknowledge it's important what you're discussing, Eriko. I think in encouraging that through education for appropriate weight management, lifestyle modification, and exercise, that lifestyle modification includes, getting off the alcohol that's going to be impacting the liver as well. So I think being less paternalistic in the questions and trying to do that through education and information, I probably is our best bet at this point.
yeah. And I mean, and theoretically, right, if the primary driver of the steatohepatitis was alcohol, they wouldn't ever get one of these diagnoses. Correct? I mean, they could get the mixed picture, but if they're getting NASH or MASH, theoretically, the provider's already excluded alcohol as being the primary driver.
Correct. Though if we remove, and I think you can also tell the difference in biopsy, though I'm not a hepatologist. So if we adjust the biopsy requirements, we could be more specific on clarifying that this is due to non-alcoholic disease and not a mixed picture.
Yeah, and I think, I mean, that's the way I would approach it rather than asking the alcohol questions, because I mean, again, it's valid and, it should be a discussion to anybody who's got any kind of liver disease, but I don't know that it's necessarily something that I would want to screen in the PA or renewal criteria. That's just my opinion.
Thank you. I just wanted to bring it up, but I also understand at the same time that how, the resources, and I just kind of want to be fair as much as possible. So,
Really,
yeah,
really
thank you.
appreciate that, Eriko. Thank you.
And we do rely on specialists quite often. And I don't know if this is the space where a specialist might be helpful if we required a dietitian consult. I don't know how much they have to do with alcoholism versus other parts of the diet, but that could be a consideration here.
Other questions or discussion, or a little bit of public comment ready?
I think we're ready.
All right. Thank you for giving me confirmation. So William Lamb, a representative from Madrigal Pharmaceuticals, the manufacturer of Rezdiffra. I have made you a co-host. Are you able to unmute your line?
Yes, can you hear me?
Can hear you loud and clear. And with that, the floor is yours.
Thank you. Good afternoon. My name is William Lamb. I am a scientific director in medical affairs at Madrigal Pharmaceuticals. Thank you for the opportunity to provide information on Rezdiffra. Rezdiffra is a thyroid hormone receptor beta agonist indicated in conjunction with diet and exercise for the treatment of adults with NASH with moderate to advanced liver fibrosis, consistent with stages F2 and F3. This indication is approved under accelerated approval based on improvement of NASH and fibrosis. Rezdiffra is the first and only medication approved by the FDA for the treatment of NASH. The efficacy of Rezdiffra was evaluated based on analysis at month 12 of the MAESTRO-NASH trial, an ongoing 54-month randomized double-blind placebo-controlled trial. At month 12, the 80 milligram and 100 milligram daily dosages of Rezdiffra demonstrated improvement on the histopathology endpoints compared to placebo. The Rezdiffra prescribing information does not include a specific requirement for liver biopsy in order to confirm diagnosis of NASH with stage F2 or F3 fibrosis or to initiate therapy. In the pivotal MAESTRO-NASH study, biopsy was required to address the FDA regulatory requirement for accelerated approval. However, according to a real-world analysis of the Optum database, liver biopsy is infrequently performed, less than 10% of the time, as a diagnostic procedure in patients with NASH. Based on a recent 2024 expert panel recommendation for initiating and monitoring resmetirom in patients with NASH, liver biopsy remains a potentially important diagnostic option, particularly in instances of discordance between non-invasive tests. Studies have demonstrated that employing non-invasive tests can increase precision for staging hepatic fibrosis and help predict the risk of overall and liver-related outcomes. Acknowledging the impracticality of liver biopsy on a large scale, the FDA has left the non-invasive identification of eligible patients up to the clinician. Biopsy is invasive and may also be limited by cost, sampling error, and procedure-related morbidity and mortality. As per guidelines endorsed by the AASLD, AGA, and AACE, an algorithm for fibrosis risk assessment suggests that adult patients who are classified as high risk for NASH with moderate to advanced fibrosis should undergo primary risk assessment utilizing the FIB-4 measurements. Patients with a FIB-4 score indicating a moderate to high risk should proceed to a secondary risk assessment using either FibroScan VCTE or ELF. If the results of the secondary risk assessment continue to indicate an intermediate or high risk of fibrosis, it is recommended to refer these patients to specialized care for proactive management and monitoring. In situations where there is uncertainty in diagnosis, such as when non-invasive tests produce conflicting or inconclusive results, a liver biopsy should then be considered. In closing, I want to thank the Oregon Committee for your time and consideration and allowing treatment-eligible patients in Oregon access to Rezdiffra. Thank you, and I'd be happy to answer any questions.
Great, thank you, William. Any questions from the committee? All right, thank you. Next, we have Kat Kachatourian, pharmacist with Novo Nordisk. Are you able to unmute your line?
Yes, Roger, I am. Are you able to hear me?
Loud and clear, and the floor is yours.
Perfect. Thank you. And I want to thank the committee for your time today, and I will actually yield back my time today. And I'm happy to answer any questions related to semaglutide if the committee has any.
Fantastic. Thank you very much, Kat. Committee, do you have any questions of Kat while we have her availability? All right. Appreciate giving the time back. I'm going to turn it back over to you, Sarah, for the recommendations.
Sure. Right now, we have recommendations for implementation of the PA criteria for resmetirom to ensure safe and appropriate use. And then we have the recommendations for the edits to weight management to include coverage for specific GLPs with compendia support in patients with NASH who are adults with overweight or obesity, and then to remove the age restrictions for people with established kidney disease with overweight or obesity because of the increased risk of recurrent MACE in this population. I know we have some kind of questions on the table as far as adjusting biopsy, how to then include possibly metabolic risk factors versus ruling out other conditions such as concomitant alcohol use, and then adjustments in the weight management drugs for defining NASH more specifically, perhaps. So I want to open it up to committee to discuss and amend as needed. Sarah, should we bring up the PA criteria to see again? Does anyone have a preference on which one?
Sure, I can do that.
If we can do the, I think that the one for resmetirom, am I saying that right? That one, the only change we were proposing was really around the removing the biopsy and adding the PA criteria to include, essentially ruling out other causes and the comorbid metabolic complications, correct?
That is what I captured as well.
Okay.
And is it 3 of 5, as in the trial, 1 of 5 as in the definition of MASH? Where are the thoughts on that? And those 5, just to remind you, are increased BMI or waist circumference, diabetes, hypertension, and then hypertriglyceridemia and decreased HDL are both 1. So those are the 5.
I think I would lean towards going with the higher, like do 3 of 5 to start. We can always revise that down the road if we find that, we're excluding people who really need access. But I would say maybe take a slightly more conservative approach to start, and then knowing that this is probably going to be something we're going to revisit a few times, at least going forward.
Okay.
I'm assuming that's a motion and I'll second it.
I'm not sure. Am I even allowed to make motions? I don't know about that.
Absolutely.
Oh, okay.
Sure.
Yeah, I did not realize I could make motions. So yes, that is my motion to change the biopsy requirement to include exclusion of other diagnoses and 3 of the 5 comorbid conditions.
Okay.
And Doug seconded. Thank you.
Oh, and Doug seconded. That's right. Okay, so all those in favor?
Aye.
Aye.
I
Aye.
Anyone
Aye.
opposed? Oops, sorry. Anyone opposed? And abstain? Of course, my
Great.
dogs chimed in, so I think they're abstaining. All right, motion carries. Thank you.
Would the committee like to see this with its final wording at the next meeting? Or just emailed out to make sure that the intent is fully captured when it's written out, since you don't have it in front of you?
I'm fine with email.
Okay. Okay, I guess we can go to the next one, the weight management drugs PA. And I know there were some issues from previous discussion on the table of if we should continue the biopsy in this one or mirror it to the other criteria. The other criteria does include restriction to a specialist. So potentially including that, as well as defining the fibrosis stage for NASH. I think those were the discussion issues on the table for this one, as well as just generally, do we want to add compendia support of these agents for patients who have concomitant overweight and obesity and NASH?
Well, I don't think that we need biopsy. Consistent with, and it needs to be more than 1. And I'd say grade 2 or 3.
Yeah, agreed. And I see what you're saying, though, that if we're trying to mirror these, if we have the requirement for consultation in one, do we need to have it in the other? Even though I don't necessarily love that, but I can see why we would want to be consistent across both.
Right. The other drug has the FDA approval and 900 patient study. These are smaller studies, so.
Yeah, but also a lot more experience with these drugs.
That's true. A lot more safety evidence as well. And they do have overlapping side effects as far as initiation with nausea, vomiting, diarrhea, that kind of thing.
Right.
Well, one of the advantages of consultation would be that broader consideration of options, the clarity of the diagnosis, and that I think what we've been dancing around is, oh, this is going to be an easy way to, an end around to medicate not paying for obesity drugs.
True. Well, in
So by
that,
having
yeah,
a more consistent approach, then we wouldn't be doing that.
right. And if we take the approach that, about being more conservative to start, maybe we start with the specialist requirement, and then we could always revisit that later. What do you guys think about that?
Well, and it would say it doesn't have to necessarily be prescribed by the specialist, right?
Exactly, just in consultation.
Yeah, I think that's fine.
So I'm hearing remove biopsy, prescribed by or in consultation with, and stage 2 or higher.
Yes.
What about the metabolic risk factors as we are adding in the other one? The ruling out and metabolic risk factors.
Oh yeah, I think that should be in there if we remove the biopsy.
The 3 or more.
Yeah.
So consistent with what I'm adding to Resdifra. Okay.
I guess that's my motion. What Roger just said, how's that?
I second that motion.
Okay. All those in favor?
Aye.
Aye.
Aye. Aye.
Opposed? Abstain? All right, motion carries. Thank you, guys. That was a good discussion.
All right. It was a good discussion. So as expected, we're a little behind schedule, but I propose that we take a 10-minute break at this time. Oh, I'm sorry, Sarah. What was that?
Sorry, just making sure. Did we actually vote to implement PA criteria for the drugs?
I think so.
Okay.
I thought we
cool.
did on both with those.
With the amended, as amended. Okay, got it.
Yeah. Am I getting ahead of myself? Did I miss anything for this topic?
Age for cardiovascular risk.
That was in the criteria already as proposed, so we didn't have to amend that with the criteria. You had, I appreciate your comments to support where we had gone with that with the evidence review, but the proposed criteria we brought forward included that removal.
All right.
Excellent. Thank you, Sarah. I want to make sure. Both Sarahs, you concur we've got everything covered for this topic?
I think so. Thanks everybody for hanging in there. I know it was a long one.
All right. So with that, propose we take a 10-minute break, and then we'll reconvene and start with the TIMS as our next subject. All right. Hope people enjoy a quick break. Thank you. Well, it seemed like a very fast and quick 10 minutes to me, so I hope everybody had plenty of time to get a snack or refresh or do what you need to do. So we still have a bit of material to go over. As I mentioned at the top of the order, we're planning to switch to move to the targeted immune modulator DERP summary at this point. If you are following along in the packet, that starts on page 162, and we'll turn it over to Deanna.
Thank you, Roger. That was a quick break. I would agree. If we can go to the next slide, please. As Roger mentioned, we will be looking at Drug Effectiveness Review Project Reports, or DERP. That'll be the abbreviation we'll be using throughout this. So in April 2023, DERP published a report on the targeted immune modulators, or TIMS, for Crohn's disease and ulcerative colitis. And then this year, and I apologize for that typo there, should be 2024. They looked at the dermatologic conditions, plaque psoriasis, psoriatic arthritis, and generalized pustular psoriasis. Generalized pustular psoriasis is a new indication because there is a new drug approved for that indication. Next slide, please. So these are the DERP research questions. Basically, they were asking, what's the comparative efficacy and harms for the TIMS in those specific conditions? And then that third question is based on, is there any difference in the subgroup analysis? Next slide, please. To make things a little bit easier, I put this table together so you know which drugs we're talking about. This is also on page 170 of the packet if you're following along. So the highlighted drugs in red are new to this review. So mirikizumab, which is approved for ulcerative colitis, and then etrasimod there at the bottom. It's a new S1P or sphingosine 1 phosphate receptor inhibitor. It's approved for ulcerative colitis. And then two of our agents, risankizumab, got approval for Crohn's disease or CD, and upadacitinib got approval for both Crohn's and UC. So we'll go to the next slide, please. I'm going to run through the DERP conclusions, which are in your packet. We tried to focus on just the new evidence. The DERP summary, if you look at it, they summarized all the old evidence as well. But to make it a little bit easier to sift through all the evidence, we're just looking at new evidence. So there was one new randomized control trial that looked at the safety and efficacy of adalimumab compared to ustekinumab in people with Crohn's disease. And they noticed that a similar percentage of patients achieved clinical remission at 52 weeks. And there was no difference in overall adverse effects, and the grading of the evidence is presented there for you. Then they also looked at vedolizumab compared to the TNF inhibitors, and that was in 5 cohort studies. Basically, they were looking at the rate of serious infections, and they found there was no difference statistically in the incidence of serious and opportunistic infections from the two drugs. And then another cohort study assessed the risk of malignancies. Refer back to that slide. Vedolizumab is an integrin receptor inhibitor, so it works a little bit differently than the TNF inhibitors, but there was no difference in malignancies. Next slide, please. Then looking at the targeted immune modulators in ulcerative colitis, there was 6 new cohort studies that looked at head-to-head safety comparisons. And when they looked at tofacitinib compared with the TNF inhibitors, and as a reminder, tofacitinib is a JAK inhibitor. So there was no difference in the risk of infections or cancer. They did notice, this was all very low certainty of evidence, a higher rate of herpes zosters. And then a particular adverse effect of interest, especially with the JAK inhibitors, is adverse cardiovascular events because of the black box warning for the JAK inhibitors regarding the risk of MACE or major adverse cardiovascular events. And so there was no statistically significant difference there. Then again, those same cohort studies also looked at the risk of serious infections for vedolizumab with TNF inhibitors, and they did find less serious adverse events and less serious infections with vedolizumab compared to the TNF inhibitors. And finally, there was no difference in the risk of malignancy. Next slide, please. And then finally, we do have 2 new TIMs, as I mentioned earlier, that were approved for use in ulcerative colitis. So etrasimod or Velsipity, both of these were placebo-controlled trials. And in the placebo-controlled trial, there was a statistically significant improvement in the modified Mayo Clinic score, which is a way of assessing clinical remission for UC. If you're interested in the outcomes, those are all summarized in Appendix 2. I forgot what page number that's on, but there is a summary of all the different outcomes that they look at. And then when they studied intravenous mirikizumab compared to placebo, that also showed a higher incidence of remission in patients with UC compared to placebo. low certainty of evidence for that particular study. Next slide, please. So the final summary was looking at mixed populations. So it was people with Crohn's disease and ulcerative colitis. So there was 2 cohort studies that looked at ustekinumab with TNF inhibitors, and one of the there was 2 cohort studies. The larger one showed no difference, where the smaller one did show a lower risk of serious infections with ustekinumab compared to TNF inhibitors. Ustekinumab is a IL-12, IL-23 inhibitor, as opposed to the TNF inhibitors. Then there was a 3rd cohort study that looked at adalimumab and infliximab, 2 TNF inhibitors, versus vedolizumab with each other, and also ustekinumab, and they showed that vedolizumab had a lower risk of serious infection compared to the TNF inhibitor infliximab, and there was no other significant differences that were observed. All right, I went through that pretty quickly. Now we're going to move into plaque psoriasis. So these are the TIMs that are approved for plaque psoriasis, psoriatic arthritis, and that new indication I mentioned, generalized pustular psoriasis. So we have 3 new drugs. We have bimekizumab. I'm sorry if I'm mangling the pronunciation of that. It's approved for plaque psoriasis as a sub-Q injection. It joins the other IL-17 inhibitors. Then spesolimab is an IV drug that's approved for generalized pustular psoriasis. It's also available as a sub-Q formulation. I neglected to update that particular table. And then finally, we have the one at the bottom, which is a TYK2 inhibitor, which is similar to the JAK inhibitors. It's an oral drug approved for plaque psoriasis, Sotyktu or deucravacitinib. Next slide, please. So the DERP conclusions for TIMS and plaque psoriasis, there was 1 small open label randomized control trial, very small, only 40 patients, that looked at patients that still had a elevated PASI score after getting ustekinumab. So they received either guselkumab or secukinumab, and the major endpoint was improvement in the treatment refractory plaques. And there was no difference in clinical improvement that was observed between those 2 drugs. Then there was another randomized control trial that looked at risankizumab compared to the PDE4 oral drug, apremilast. And it showed that people that got the risankizumab seemed to have better improvement compared to the apremilast. And there was also less adverse effects with the risankizumab. Next slide, please. So continuing with the TIMS and plaque psoriasis, 2 new randomized controlled trials looked at the new TYK2 inhibitor compared to apremilast in patients that had moderate to severe plaque psoriasis. And in the first randomized control trial, there was a better response rate with deucravacitinib compared to apremilast for the PASI score, PASI 75. And then in the second randomized control trial, they had a similar response where the oral TYK2 inhibitor was better than the PDE4 inhibitor. Next slide, please. In terms of the DERP conclusions for TIMS in psoriatic arthritis and generalized pustular psoriasis, there was no new evidence for comparative efficacy or harms in psoriatic arthritis. There was no comparative randomized control trials for the new IL-36 antagonist. It was all based on a placebo. The FDA approval was based on a placebo-controlled trial. And then no new evidence was identified to evaluate differences amongst the subpopulations. Next slide, please. Okay, there were quite a few guidelines. So I'm not going to read everything about the GRAPPA highlight updates, but basically they're just providing guidance about which class of drugs should be preferred depending on what sort of symptoms patients are presenting with psoriatic arthritis. So whether it's peripheral arthritis or if they've got active enthesitis, or if they have psoriasis in addition to the psoriatic, joints. So basically, they're just recommending TNF inhibitors, IL-17 inhibitors, and IL-23 inhibitors, as well as JAK inhibitors for all of those situations, especially if they have tried oral treatments or if they've tried other agents, either the conventional treatments or some of the other biologics, before advancing to the next phase. Next slide, please. The NICE guidance is pretty substantial as well. Each of the NICE recommendations are drug specific, and basically they're just recommending all of the TIMs that we'll be discussing as second line therapy. So risankizumab and upadacitinib are recommended for moderate to severe Crohn's disease if they haven't responded to TNF inhibitors or if they're contraindicated. Same with mirikizumab and upadacitinib. They're recommended for UC in adults if conventional treatment or the TNF inhibitors aren't tolerated. And then ozanimod, the other SP1 receptor inhibitor, is recommended for moderate to severe UC if conventional treatment or infliximab has not worked. Next slide is more NICE guidance. So looking at the bimekizumab and deucravacitinib, those other two new drugs, they're recommended as second-line agents for treatment of plaque psoriasis by NICE if they meet certain conditions regarding the severity of the psoriasis and if it hasn't responded to other systemic treatments such as cyclosporine or methotrexate, and the same with deucravacitinib. Next slide, please. We also have some guidance for psoriatic arthritis from NICE. So they came out with guidance for guselkumab, risankizumab, and upadacitinib. They're recommended as monotherapy or in combination with methotrexate if the psoriatic arthritis in adults has not responded to other disease-modifying agents such as methotrexate. And they're only recommended if they've tried 2 conventional DMARDs and they've tried a TNF inhibitor. Next slide, please. We have a lot of new indications and formulations as well. So I separated these out by the disease state. So for Crohn's disease and UC, we talked about the fact that upadacitinib has approval for UC and CD in adults that have moderate to severe disease activity if they haven't responded to a TNF inhibitor. Then we have etrasimod, which is approved for ulcerative colitis, and mirikizumab, which is also approved for moderate to severe UC in adults. I mentioned there's a new sub-Q formulation of vedolizumab for treatment of adults with moderate to severe Crohn's disease and UC. And then risankizumab is also approved for adults that have moderate to severe ulcerative colitis. Next slide, please. So here's the updates for the dermatologic conditions as well as pediatric juvenile idiopathic arthritis. So bimekizumab has been approved for adults with moderate to severe plaque psoriasis if they're candidates for systemic therapy or phototherapy. Same with deucravacitinib. The spesolimab was approved for the generalized pustular flares as an IV infusion initially, and then the indication was expanded to include adults and pediatric patients aged 12 and up in March of 2024. And that same month, a new sub-Q formulation was also approved for use in patients to maintain to keep the disease in remission after the flare has been resolved. And then apremilast has been approved for treatment of moderate to severe plaque psoriasis in pediatric patients that are aged 6 to 17, as long as they're over 20 kilos. And seralimumab has the approval in patients that weigh 63 kilos or greater that have the juvenile idiopathic arthritis. Next slide, please. So our recommendations are to update the TIMS PA criteria as outlined in Appendix 4, including implementation of tiered step therapy for common diagnoses. And I'll get more into detail about that as we go through the PA criteria. And then we'd like to update the clinical PA criteria for the TIMS that have expanded indications, as well as the 5 new drugs. So etrasimod, mirikizumab, bimekizumab, deucravacitinib, and spesolimab, we would like to maintain those as non-preferred on the preferred drug list, and we will review costs in exec session. So now we'll go through the changes in the PA criteria. And similar to the TIMS for asthma and atopic dermatitis, Sarah Servid invested quite a bit of time in trying to consolidate this PA criteria because it had become very, very long. There was a huge table that had all the TIMS listed in it with all the different diagnoses. So we decided to make some changes. So nothing has changed on this first page. You go to the next slide, please. So what we've done is implemented 3 tables that basically break down the targeted immune modulators into the 3 big categories. The first being rheumatoid arthritis and the associated conditions that are similar to RA. So tier 1, what we would like to do is call that preferred first line. And then tier 2 would be preferred second line. And so this is what our PDL status currently is. That may change in 2025. But for now, this is how our tiering is organized. And then tier 3 is basically all the non-preferred third line agents. So to get to tier 1, to get to tier 2 or tier 3, they would have to step through tier 1. If there are no medications available in tier 1, then they would start with tier 2 to step through tier 3. For example, you'll notice the column all the way to the right, the non-radiographic axial spondyloarthritis, Enbrel or adalimumab, neither one is approved for that. So you would go right to secukinumab in adults if you had somebody with that indication. Sarah, do you have anything to add about the tiering?
Don't think so.
If you want to jump in here, feel free. So next slide is the drugs for the dermatologic conditions. So plaque psoriasis, psoriatic arthritis, and then hidradenitis suppurativa. There are 2 medications that, in addition to dupilumab, which is not part of this PA criteria, that's in the asthma and atopic dermatitis criteria, but there are 2 drugs that are approved for HS. So similar thought with the preferred first line, stepping through those before you get to tier 2, and then before you get to tier 3, stepping through the preferred tiers before you get to a non-preferred agent. Then the last table is the shortest one, the Crohn's disease and ulcerative colitis. You'll notice there are no tier 2 drugs approved for that, and only adalimumab has the approval for CD and UC. Enbrel does not have those FDA-approved indications. Table 4 is on the next slide, and this is the catch-all table, basically for all of the what you might consider rare diseases or diseases that we don't see as frequently as the other 3 tables. There is no tiering in this because there's no stepping through. Generally, these are the only drugs that are approved for those specific indications. This used to be in that big table all the way to the right. So by making this a separate table, it should make it a little bit easier for reviewing the PA. And you'll notice almost there, let's see, under the S's, this is where we put the spesolimab because it's the only drug that has the indication for generalized pustular psoriasis. So we didn't think it fit with the plaque psoriasis drug. So we put it on this table. Next slide, please. So this table is just a summary of first-line conventional therapy that's recommended. So again, consolidating the questions so that we don't have to ask a specific question for each indication, but we can just refer to this table to say, have they tried conventional therapy before they move to a targeted immune modulator? Next slide. This is just a summary. The S1P receptor modulators are have a lot of safety concerns. So we just put, instead of asking those specific questions, we put them all in a table and just refer to this table for that assessment. Next slide, please. Basically, there was no changes to these first 4 questions. As I mentioned earlier, question 3 is our standard EPSDT question. And then question 4 is just referring to make sure that the drug is being requested for an FDA-approved indication as outlined in those 4 tables. Next slide, please. Then we added question 5 to make sure it's being prescribed by a specialist and that they may have had an adequate response to other FDA-approved TIMS. This is because sometimes we see use of TIMS before stepping through adalimumab or Enbrel. They might switch to another TIM. So we wanted to have a path for access in case that situation would arise. Nothing else changed in questions 6, 7, or 8, except for adding the tables about what they've tried before. Next slide. This is different. Question 9 is a little bit different than what's presented in the packet in that we did ask if it's for a preferred tier 1 product. But then we added, what if there is no tier 1 product, like I pointed out on that first table. So we added the verbiage about or either a tier 1 in table 1, 2, 3, or a preferred tier 2 product if no tier 1 product is available. So that's slightly different from what's in the packet. None of the other questions have changed. We can go to the next slide. Everything on here is the same, just consolidating the S1P receptor modulator questions into table 6, and then kind of keeping the question about the cardiac risk factors. That is a risk factor with all the S1Ps. And if they do have cardiac disease, asking that they be referred to a cardiologist for assessment. And then question 19 just gives guidance for the duration of the approval, depending on the indication. And then the next slide, I believe, is the renewal criteria. So nothing is really changed with this, just basically asking for improvement of whichever condition the targeted immune modulator was prescribed for. And with that, I will open it up to any questions. Let's go to the recommendation slide. Well, I already talked about the recommendations. I guess, are there any questions from the P&T committee about the DERP reports or the changes to the PA criteria? I think we have public comment, correct, Roger?
Yes, we do. We have 4 representatives from manufacturers that have signed up. Again, give the committee a chance to find their mute buttons and see if they had any questions for you, but great job. You're very adept at these huge topics. Well, if questions come up, that's great. First, we have Tyler Lincoln with Arcutis Biotherapeutics. Tyler, I made you a co-host. Are you able to unmute your line?
Yes, can you hear me okay?
You bet. Can hear you loud and clear.
Awesome. Thanks everyone for having me on. My name is Tyler Lincoln. I'm a Senior Director of Field Medical Affairs with Arcutis Biotherapeutics. I'm here today to talk about ZORYVE. Zoryve cream or roflumilast cream comes in 2 formulations, a cream and a foam. It's currently approved for atopic dermatitis and seborrheic dermatitis and plaque psoriasis. All 3 of those diseases are disfiguring, debilitating, and have a high impact of quality of life. Current topicals that are out there have limitations, as the topical steroids cannot be applied chronically and for long periods of times, and then also tolerability. Zoryve or roflumilast 0.3% and 0.15% cream and 0.3% foam. It's steroid free. It's a PDE4 inhibitor, which is highly selective and more potent than previous PDE4 inhibitors. It's approved in plaque psoriasis down to the age of 6, down to the age of 6 in atopic dermatitis, and down to the age of 9 in seborrheic dermatitis. There's no label restrictions. It can be applied to all body surface areas for as long as you want, no duration of use. It's indicated for use in intrinsic areas in psoriasis. There's no black box warning, and it's easy applied once a day. Zoryve cream was evaluated in 2 randomized placebo-controlled trial, the DERMIS-1 and DERMIS-2, about 881 patients in mild to severe plaque psoriasis. They have evaluated IGA scores and the success of a 2-grade improvement. Around 40% of patients in the Zoryve arm achieved this 2-grade improvement, compared to around 6% of patients in the vehicle arm. Zoryve is also effective in intrinsic areas, so in the groin, the axilla, underneath the breast, and we saw IGA scores of 71% versus 13%, and then 67% versus 17.4%. Adverse events greater than 1%, diarrhea, headache, nausea, application site pain. Although Zoryve is formulated for tolerability, it is well tolerated and able to apply to all skin types. Safety and efficacy was consistent across all 3 indications. Therefore, we're respectively asking the committee to consider adding Zoryve cream and foam to the PDL for a product for atopic dermatitis, psoriasis, and seborrheic dermatitis, and open up to any questions you all have.
Appreciate that, Tyler. Questions for Tyler? And a little point of clarification, the DERP summaries that we're reviewing, I don't think included your medication in those drugs. And so it would be a therapy, I think, that we might be requiring or looking at, albeit non-preferred, as a step-through therapy before we get to some of these other TIMs. But I need to clarify that, so it kind of caught me off guard. But I don't know if you can speak to that, Deanna. But again, for what you presented, I don't know if the committee has any questions.
I have to look too, but I can't remember if roflumilast is approved. I think it's only approved for mild to moderate psoriasis, and mild psoriasis is not funded by HERC. I think it might be under some other PA criteria, because I think we've looked at it before. I'd have to go look at the PDL to double check it, and I can do that.
So I might have done a better job with my due diligence or spoken with you about it, Tyler, but nonetheless, you got 3 minutes in front of the committee. So appreciate the information that you shared.
Thank you.
You bet. Rochelle Yang, Teb, are you able to unmute your line?
Yep, I'm here.
Awesome. We hear you loud and clear, and the floor is yours.
All right, perfect. Thanks, Roger. My name is Rochelle Yang. I'm with Teva Medical Affairs. Just wanted to share some very quick information about Simlandi, which is a biosimilar to Humira, which is included in the TIMS class. Simlandi is a high concentration citrate-free formulation and is the only biosimilar that is interchangeable with the high concentration 40 milligram per 0.4 milliliter strength of Humira, which is the most widely used Humira formulation nationally that we see. What that interchangeability designation allows in Oregon is that unless the prescription indicates a dispense is written or substitution not required, a prescription for the reference product can be substituted at the pharmacy for that interchangeable biosimilar without the need for prescriber intervention, i.e. a new prescription. So this might allow for a more efficient and seamless transition process for patients. Simlandi was approved as a 40 milligram per 0.4 milliliter autoinjector with a press-on skin mechanism. The device also had received the Arthritis Foundation's ease of use certification, essentially easy to use for patients with arthritis that may have limited dexterity in their fingers. There were 2 randomized controlled phase 3 studies that were conducted for Simlandi. There was a biosimilarity study of 413 patients, as well as a switching study of 567 patients. That essentially showed no significant differences in outcomes between patients using Simlandi and reference product Humira in terms of safety, efficacy, pharmacokinetics, and immunogenicity. Biosimilars as a whole have driven competition and have contributed to significant savings for the healthcare system. Currently, all biosimilars to Humira are non-preferred Tier 3 on Oregon State's PDL. We respectfully request the committee to consider making biosimilars, including Simlandi, accessible for patients in Oregon. Thank you.
Great. Thank you, Rochelle. Any questions from the committee for Rochelle?
Roger, I have an update on roflumilast. We have PA criteria for topical drugs that are used in inflammatory skin conditions, and that's where the PA criteria for that drug reside.
Great. Thank you for the update on that. Next, we have Melinda Turkington from UCB. Melinda, are you able to unmute your line?
I am. Thank you.
All right. The floor is yours.
Good afternoon. My name is Melinda Turkington. I'm a medical outcomes liaison with UCB. Thank you for the opportunity to join the meeting today. I'd like to update you with clinical information on bimekizumab, brand name Bimzelx. It's indicated for the treatment of moderate to severe plaque psoriasis in adult patients who are candidates for systemic therapy or phototherapy. It's available as a prefilled syringe or an auto-injector. The recommended dosing regimen for Bimzelx is 320 milligrams given as 2 separate 160 milligram injections administered subcutaneously at week 0, 4, 8, 12, and then at 16. For patients weighing less than 120 kilograms, it would be every 8 weeks after. For those patients that are greater than 120 kilograms, consider continuing that dosage of 320 milligrams every 4 weeks. Bimzelx is a humanized immunoglobulin IgG1K monoclonal antibody with 2 identical antigen binding regions that selectively bind to IL-17A and IL-17F. It inhibits their interactions with the IL-17 receptor complex. IL-17A and IL-17F are naturally occurring cytokines that are involved in the normal inflammatory and immune responses. So Bimzelx is going to inhibit the release of pro-inflammatory cytokines and chemokines. 3 multi-center randomized double-blind studies enrolled a total of 1,400 patients, 18 years and older, with moderate to severe plaque psoriasis. At week 16, 85 to 91% of the patients had achieved PASI 90. 84 to 93% of the patients had reached IGA 0/1. Additionally, 59 to 68% of the patients had achieved PASI 100 or completely clear skin. As it was quoted on page 178, evidence from clinical trials show that bimekizumab is more effective than adalimumab, the current preferred second-line secukinumab, and ustekinumab. There are no contraindications. Bimzelx's most common adverse reactions of greater than 1% are upper respiratory infection, oral candidiasis, and headache. Bimzelx may increase the risk of suicidal ideation and behavior. A causal association between the two has not been established. Bimzelx may increase the risk of infections, evaluate patients for tuberculosis, test liver enzymes at baseline and then periodically during treatment, according to routine patient management. Cases of inflammatory bowel disease have been reported in patients treated with IL-17 inhibitors. Please refer to Bimzelx prescribing information for the full safety and efficacy profile. Thank you for your time and consideration. We respectfully ask for second-line preferred status, and please let me know if you have any questions or concerns. And again, thank you so much for the time and allowing me to speak today.
Appreciate it, Melinda. Questions from the committee for Melinda? All right, appreciate your time. Next, we have Aaron Nowak from AbbVie. Are you able to unmute your line? I guess let me make sure that I made you a co-host. so that you can unmute your line. Yes, I did. And it looks like you're unmuted. We can't hear you.
You can hear me now?
Lightly. Are you able to speak up a little more?
I am. Yes. Can you hear me now?
There you go. Yep. Hear
Awesome.
you clear now.
Great.
Thank you.
Awesome. Hello, my name is Erin Novak, Medical Outcomes and Science Liaison with Medical Affairs at AbbVie. Thank you for allowing me a few minutes to speak on two products today. First, upadacitinib or Rinvoq, and then also Skyrizi or risankizumab. And I'll be providing information on these two therapies to support the request of the committee to add Rinvoq and Skyrizi to the preferred drug list in a label appropriate manner. Per label, upadacitinib or Rinvoq is approved following one or more TNF blockers for all indications, except atopic dermatitis, where it is approved following other systemic drug products. In the targeted immunomodulator space, there are many therapies with a variety of mechanisms. However, there does continue to be significant unmet need, with up to 60% of patients failing to achieve treatment goals that are set by guidelines, leaving patients with significant morbidity and disease burden. But Rinvoq, an oral JAK inhibitor, now with 8 indications, offers meaningful clinical attributes across indications, and I'll touch on 4 of those. Number 1, rapid onset of action. Number 2, durable response. Number 3, ability to achieve those rigorous treatment targets that are set by guidelines, like clinical remission in RA and endoscopic endpoints and steroid-free clinical endpoints in IBD. And then 4th, there are 6 head-to-head trials versus 4 other mechanisms of action, showcasing an improvement in patient care. And these data can also help inform treatment decisions for providers. And then I'd also like to note for the committee that Rinvoq is FDA approved in most indications in those that have had inadequate response or intolerance to a TNF blocker. Thus, access to this therapy from the perspective of the state would remain the same if added to the PDL, given that this already aligns with your current PA criteria to utilize after an anti-TNF treatment. And the next, Skyrizi is approved now for 4 indications: moderate to severe plaque psoriasis, psoriatic arthritis, Crohn's disease. And then in June of this year, it was most recently approved for moderately to severe lactic ulcerative colitis in adults. Meaningful clinical attributes of Skyrizi include durability of response, number 2's ability to achieve those rigorous treatment targets as well, including but not limited to the endoscopic outcomes of IBD. And then number 3, there are also 6 head-to-head clinical trials for Skyrizi across 4 different mechanisms of action: IL-17, IL-12/23, TNF and PDE4 inhibitors, demonstrating meaningful clinical benefits and advancements against each. Both of these therapies do have a favorable benefit risk profile, and more safety information can be found at rxabbvie.com. But I'd like to end with saying, with the clinical attributes of these therapies, these are treatment options that would be beneficial to Oregonians living with autoimmune conditions, as well as to the state. And I'd like to respectfully request that Rinvoq and Skyrizi be added to the list. Thank you for your time and consideration. And please let me know if you have any questions.
Appreciate it, Erin. Committee, do you have any questions for Erin? All right, thank you. We also had a late breaking request to join us. So I have Josh Akers from Eli Lilly. He saw everybody was having so much fun, so wanted to throw his hat in the ring. Josh, are you able to unmute yourself?
Can you hear me?
We can hear you.
Fantastic. So thank you very much for my last minute addition. I don't have much to provide or today, but I did just want to make sure I'm here, an outcome liaison from Eli Lilly. I am here to represent mirikizumab. I'm not going to present any data today, but I am available if there are any questions regarding mirikizumab. If not, I am happy to yield my time back to the committee.
Great. Appreciate that, Josh. Committee, or Deanna, if you had any questions about mirikizumab. All right. Appreciate the offer, Josh. And yeah, we'll
Thank you
stop
very
there.
much.
Thank you. You bet. Deanna, I'm going to turn it back over to you to recap the recommendations.
Okay, so we want to update the PA criteria as outlined, including implementation of the 2-step therapy for common diagnoses. And then to update the PA criteria to include coverage for the 5 new drugs and the new indications. And then to maintain those 5 drugs as non-preferred products, etrasimod, mirikizumab, bimekizumab, deucravacitinib, and spesolimab as non-preferred. And then we'll review cost and exec session. So are there any suggestions for changes to the PA criteria, or is there a motion to approve?
Motion to approve the recommendations as already presented.
Do we have a second?
I'll second that.
Thank
Great,
you, Tim.
thank you. All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, motion carries. Roger, I don't know, I only heard a couple of voices, but I'm thinking nobody opposed or abstained, so I think we're good.
Yep, and I think some were hitting with the mute button, so and
Yes.
switching the phone. So I know, like,
Yeah.
so thank you for confirming. All right, I'm going to check with my coordinators quickly. Do we have time, or should we defer on the antacids? I know we have quite a bit to go over with exec session.
I think we should probably defer.
Okay, that was where I was leaning as well. So with that, we have concluded the topics that we are presenting to the P&T committee. We do need to meet in executive session to go over confidential pricing that can't be disclosed. I need to read a short blurb, but no actions will be taken in the committee. For the audience, stick around and we will reconvene to make recommendations and further deliberations. So the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive session is held pursuant to ORS 192-6602F and ORS 414-356-1 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class, as necessary for the committee to make final recommendations or to comply with requirements of ORS 414-353. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend the exec session. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session except to state the general nature of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. So for the committee, we're going to move you into a breakout room.
Give me just a second. It looks like Tim re-entered and I need to add him before I.
Yep, I'm doing that right now as a co-host, and then I'll let you put him in the room.
Okay, and there's a phone number. We lost somebody earlier from the list, and there's someone who's called in by phone. Is that a committee member that you know about? If not, I'm leaving them out. We can talk about it at exec. Okay, I'm going to open the room now.
And I'm going to pause the recording. And we are returning from executive session. Give a second for people to get reoriented and take themselves off of mute. Looks like we still have a fairly good number of people in the audience, so appreciate your patience. Recording is back on. So one of the topics that there was some conversation that we thought we should have in open session before we take the final rec is, well, I guess let's take the final recommendations. We've only reviewed one class in executive session, and for the targeted immune modulators, after review, the recommendations are to make infliximab AXXQ, which is Avsolo, and Simlandia, branded only, Amjevita, 100 milligram per mil, also known as the high concentration only, and non-branded adalimumab FKJP, which is the 50 milligram per mil or the lower concentration. Make those all preferred and make them tier 1 preferred. So they'd be the first line offers. In addition to those, this isn't a PDL change, but with that tier 1 grouping, we would make current preferred agents, Enbrel and Humira, tier 1 offers. We'd also recommend to make ixekizumab, which is Taltz, apremilast, Otezla, and tofacitinib citrate, Xeljanz preferred, and those would be in tier 2. And finally, to make secukinumab, Cosentyx, non-preferred. Any discussion around that recommendation for PDL and tiering? Questions? And if not, then we'd entertain a motion. Let's see if I can get the committee members, if you can unmute your lines.
Make a motion. I move to approve the recommendations Roger outlined. Do we have a second?
I have a second.
Okay.
Thank you, Doug.
And are we ready to go ahead and vote on these, Roger, or was there more discussion?
I think for those PDL and tiering recommendations, we're ready to take a vote. So if we have the other committee members, Samara and Rico, if you're able to take yourself off mute.
Yep. So all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, motion carries.
So the conversation just that we wanted to have was, in this space, we're seeing more and more agents and we're getting some expensive agents. And does there come a point where we relax some of the criteria so don't require a PA for everything in this class? So we have some of that step through therapy and make things available without prior authorization, potentially, so that it might increase utilization, since it's sometimes hard. Maybe lowering the barrier to initiating therapy might increase utilization on the front end. And so wanted to get people's thoughts on that space. I don't know, Stacy, if this is something you see with other payers, or if anybody has any thoughts, and perhaps not. I mean, you can leave it to us. It's kind of that magic 8-ball. We kind of monitor it, and it's some intuition or gut reaction, but again, seemed to be a conversation for the committee to consider.
Yeah. I mean, I think, I see both sides of this. And again, I don't know that we necessarily need to change it right now, but I think it is something that we consider maybe going forward. And unless the other committee members feel strongly about making that change now.
This is Tim. I don't feel strongly about making a change, other than part of the reason you have criteria is to assure appropriate safe use. It's not just about cost. So when considering taking something off of having a PA criteria, I just would want to make sure it's a therapy that we're not concerned about, like appropriate safe use.
So clinical considerations on top of just maybe financial or step through.
Exactly.
Great point. Anybody else thoughts in this space? Okay. Well, we went through a lot of information today, but again, if any thoughts come up, committee will welcome you to email us. Again, that goes in the DUR space, newsletters, or questions along this. I think we did confirm that once we make some of those modifications to some of the NASH and those criteria, we're going to send back in an email just to confirm that everything we discussed and that you voted on for approving those criteria and the amendments that went into those. Once they're all baked in there, look what you anticipate and what you were voting on. So we'll take that as a way. The next P&T meeting is going to be held October 3rd. Mark your calendars, and I'll send out an invite to put a placeholder on your calendar. And with that, thank you very much. We'll give you back 8 minutes before the 5 o'clock hour Really appreciate everybody's time volunteering for this important work, and yeah, stay cool out there today.
Yes. Thank you, everybody. And thanks, Roger and the Derm team and everybody for putting this together.
All
Thank you.
right.
Thank you.
Thank you.
Thank you.
Bye.
Thanks.